Hello dreamers, in this video we are going to talk about mood disorders. So we'll cover important mood disorders like depression, bipolar disorder. We'll cover some other mood disorders like PMDD, dysthymia, cyclothymia. We'll talk about pregnancy and various aspects of psychiatric disorders. We'll talk about important psychopharmacology, and in the end we'll talk about suicide. So let us begin. Now, mood disorders are also known as affective disorders. So in the basics we have discussed, both mood and affect are related with feelings or emotions. So sometimes these terms are used interchangeably. That is, mood disorder is also known as affective disorder. And as the name suggests, in mood disorder there is predominantly abnormality of mood. Now before beginning, let us talk about some important concepts. Now, this abnormality of mood we can divide into two. One is when the mood is sad. The person feels very low, patient feels very depressed. On the other hand, the mood may be elated. Elated is when the person is excessively cheerful. Person is happy without any reason. And sometimes it can also be irritable. Irritable means that person get angry on small issues or sometimes without any reason. Now, based on this concept, we can broadly divide the mood disorders into two. One is depression and the other is bipolar disorder. Now, in depression, the mood is low. So, let us say if the lower axis represents sad mood and the above axis represents elated or cheerful mood, in depression, the mood of the patient is sad. Okay, so in depression the mood is sad. While in bipolar disorder, sometimes the person may be in a state when the mood is sad or the person is low. On the other hand, the mood may also be at times be very happy. That is, it may be on the other pole. So patient may have manic or hypomanic symptoms in which the mood is generally elated and sometimes can also be irritable. So if you can see in bipolar disorder, so why it is called bipolar disorder, as you can appreciate, the mood abnormality can be seen in both the poles. So that is why it is known as bipolar disorder. Now, also in depression, sometimes patient may have just single episode or a single period of time when the mood is abnormal. And sometimes these episodes can occur repeatedly. So it can occur even more than one time. Now, if you can appreciate what is happening in between each of these abnormal states, if you can see, there is a period of normal mood. That is, in between, the mood becomes absolutely normal. And again, after some times, patient may show abnormality. So inherently we say, in fact, these mood disorders are episodic illnesses. These are episodic illnesses. That is, they occur for some time in an episode and after some time the episode subsides. Person becomes normal. And again, these episodes can occur again. So generally we say inherently since these are episodic illnesses, so an untreated episode of depression. So if you don't treat an episode of depression, ultimately after some time the person will become normal. So untreated episode may last from 6 months to 13 months. But of course, we treat because patient is suffering. So treatment generally reduces the duration. Similarly, untreated manic episode generally may last up to 3 months. Let us talk about the first important disorder, that is depression. Depression is also known as major depressive disorder in DSM-5. Simply it is sometimes also you can say as depressive disorder. And also sometimes it is known as unipolar depression. So why unipolar? If you can just appreciate in this diagram, even in bipolar disorder, you can see episodes of depression. But in bipolar disorder, patient is also having abnormality on the other pole. That is, manic or hypomanic episode is also occurring. While simply in depression, there are abnormalities always in the lower pole. So that is why this may also be called as unipolar depression. Now, so here depression or depressive disorder, there are only depressive episodes. There are no manic, hypomanic or mixed episodes. Okay, we'll learn about it when we'll talk about bipolar disorder. Now, the epidemiology, lifetime prevalence of depression is, so according to the latest textbook of Kaplan and Sadok synopsis, the latest edition says it is 10.8%, while earlier studies would say that it was 12%. Okay, so now you can remember 10.8%. Depression is the most common mental disorder in India. So if you exclude tobacco use disorder, depression is the most common overall psychiatric disorder in India, and this is according to the National Mental Health Study, which was conducted by NIMHANS in 2015-16. Now, when we talk about globally, most common mental disorder in the world, okay, so there are many studies and surveys conducted by World Health Organization which have found that anxiety disorders as a group, they are the most common psychiatric abnormality or mental disorders. And in that, if we talk about individual disorder, specific phobia is the most common individual anxiety disorder, while second most common worldwide is again depression. So again, depression is a common mental illness. Now, when we talk about males and females, depression is more common in females as compared to male, and the ratio is around 2:1. The mean age of onset of depression is around 40 years. So generally we say that depression is most common in middle-aged female. Now, depression can also occur even in children as well, and it is seen in children. Generally, male prevalence is equal to female prevalence. Now, also depression is more common in people who are divorced, separated, and maximum dailies. Dailies is disability adjusted life years. So out of all the psychiatric illnesses, maximum dailies is associated with depression. Okay. Now, also there is no proven association between depression and socio-economic status. Okay, so several studies have been done, but they don't show any correlation. Although it is seen, many studies do suggest that it may be more common in rural area than urban area. Okay. Now, let's talk about the etiology. Now, when we talk about the etiology of psychiatric illnesses, again, there is no one single factor in the etiology. Multiple factors may play role in the development of the disorder. So, let's talk about important etiological factors, the first being biological factors. Now, in biological factors, one important factor are the neurotransmitters. Okay. And in fact, there is a hypothesis, monoamine hypothesis, which states that monoamines like serotonin, norepinephrine, dopamine are implicated in development of depression. Especially the first two, that is serotonin and norepinephrine, are very important neurotransmitters implicated. Okay, so if you to choose two important neurotransmitters, that would be serotonin and norepinephrine. So generally what happens is both serotonin and norepinephrine are reduced in patients who have depression. Even dopamine levels are also reduced in depression. Now even other neurotransmitters are also being studied and also being seen to be implicated in the development of depression, like acetylcholine. So it is seen that cholinergic agonists in fact can exacerbate symptoms in depression. So maybe in depression again acetylcholine levels may be increased. Even GABA is implicated, and it is seen the GABA levels are decreased in the plasma, CSF and brain in patients with depression. Now, then even certain endocrinal disturbances have also been seen in patients with depression. Okay. First being, there is elevated HPA axis activity, that is the hypothalamus pituitary adrenal axis activity seems to be elevated, which can be seen as there is hypercortisolemia. So there is increased urinary free cortisol levels, plasma cortisol and salivary cortisol levels are increased, which implicate that there is a increased elevated HPA axis. Also, it can be seen the elevated axis can be demonstrated by dexamethasone suppression test, that is DST. So dexamethasone, which is a potent glucocorticoid, is given in the night and the next morning the blood samples are collected. Normally we see that after giving dexamethasone, there is a decrease in the CRS, that is corticotropic releasing hormone, is decreased, and subsequently there is a decrease in the adrenocorticotropic hormone, and subsequently there is a decrease in the cortical surge, which generally would normally occur, that would be reduced. Now, while in depression, it is seen that this cortical surge does not get suppressed, okay, even after giving dexamethasone. Okay, this is because of increase in the HPA axis in patients with depression. Now, some other important endocrinal disturbances. One very important endocrinal disturbance is hypothyroidism, which is seen to be associated with depression. Okay, many patients with hypothyroidism, may have depressive symptoms. Even subclinical hypothyroidism may also have depressive symptoms. And even at times, this is used in the treatment. Okay, so when we'll talk about the treatment, we use, in the under drugs, we use antidepressants. Sometimes thyroid hormone is used as an augmenting agent. That means along with antidepressant, thyroid hormone is given, which may improve the effect of these antidepressants, even though the patient may not be having hypothyroidism. Okay, so again, hypothyroidism is an important endocrinal disturbance implicated with depression. Even the brain-derived neurotrophic factor, BDNF factor, which is used in the maintenance of neurons, it is also implicated. It is seen, in fact, it is decreased in depression. And many times it is seen that when we treat patients with antidepressants like SSRIs, these BDNF levels increase. Okay, so again, it is also implicated. Now, next biological factors are the neuroanatomical factors. So again, there are certain areas, neuroanatomical areas, which are also known to be implicated in depression. Key areas being amygdala, hippocampus, prefrontal cortex, and the anterior cingulate cortex. Structurally, it is seen that there may be abnormalities. So structural abnormalities may be there, like hyperdensities in certain subcortical regions. So which is showing that there is some degeneration in certain areas like hippocampus, amygdala, and even the periventricular regions. Then there may also be certain functional abnormalities, like in the prefrontal cortex, PFC, there is a decrease in the brain metabolism. And in certain limbic region, it is seen that there is an increase in the metabolism. So neuroanatomical causes may also be there. Second factors are the genetic factors. Again, it is seen that genetics also play a role. Many studies like twin studies, family studies, they show that genetics also play. Now, again, there is no one particular gene which is, just the cause, but again, various studies have been going on. One important gene is the cyclic AMP response element binding protein, CREB1, which is on chromosome 2, which is shown to be strongly associated with depression. Another gene is the serotonin transporter gene, that is SLC6A4 gene. Now, this gene in the promoter region has two alleles. One is the short form, and people who have the short form of this allele, it shows that people, if they have certain negative life events, okay, so there is some adverse, or certain negative life events, and people have this short form allele, it shows that there is an increased risk of depression. So it is one of the first genes which has shown, interaction between genetics and life events, which is resulting to depression. And people with long form generally is shown to have lesser symptoms, and also they respond better with antidepressants like SSRI. SSRI is basically selective serotonin reuptake inhibitor, which we will discuss in a while. Now, genetic explains around 75% of the etiology of bipolar disorder and around 37% of the etiology of depression. So more genetic factors may be involved in bipolar disorder. Now, and as a whole in mood disorder, we say if one parent has a mood disorder, the child may have a risk of 10 to 25% of having a mood disorder. And if both the parents have mood disorder, then the risk again is increased. So again, it is telling us that yes, genetics do play a role in the development of depression and other mood disorders. More the family members, higher will be the risk. Especially if there is a family history of bipolar disorder, the risk may be even higher. Now, next theories are the psychological theories for depression. One very important psychological theory is the cognitive theory of depression, which is given by Aaron Beck. So again, sometimes this is asked, cognitive theory is for which disorder? It is for depression. Now, cognition means thinking. So according to this theory, patients who have depression, they develop certain cognitive distortions. So cognitive distortions are basically negative pattern of thinking or inaccurate ways of thinking. Now normally, if you sit silently, you may observe, certain thoughts which would occur automatically in your mind. So again, it is postulated that patients, who have depression, these automatic thoughts are generally negative. So they have automatic negative thoughts. Now, there are various types of cognitive distortions which may be seen in depression. Let's discuss some of them. First is arbitrary inference. So arbitrary inference basically means is drawing a specific conclusion without sufficient evidence. So for example, a person thinks that, he says that everyone can tell that I am a loser. Now, first of all, how would he know what everyone is thinking? And why would everyone be thinking about him? So again, it seems that, he's drawn this, specific conclusion without enough evidence. So this is arbitrary inference. Second is specific abstraction. As the name suggests, person focuses on a specific or a single detail, ignoring, other more important aspects of an experience. For example, person gave a lecture and he was applauded. Everybody gave good feedback, but he received one bad feedback. And then he started thinking that I am a bad speaker. So again, he is focused on one specific detail and he's ignored the other more important aspect of that experience. So this is specific abstraction. Next is overgeneralization. Overgeneralization, and as the name suggests, person forms conclusion on the basis of just single event. So person overgeneralizes a single event. Okay, for example, a student did not do well in a grand test and he started thinking that I am going to fail in all my other exams. So this is overgeneralization. Based on one single event, he has generalized or formed a conclusion. Next cognitive distortion are magnification and minimization. So these basically are error in evaluation of an event. In magnification, as the name suggests, it is blowing things out of proportion. So person focus on worst possible outcome or overvalues a single event. Okay, for example, somebody got 2 marks less than what he expected in a viva, and he thinks that it was my worst exam ever or it's the worst result ever. Okay, although 2 marks have not made much of a difference. So this is he's focusing about the worst possible outcome from that event. This is magnification. Now, then what is minimization? Minimization is basically to undervalue or minimize the significance or importance of an event. Okay, for example, after being told to study, everyone is telling that you should study, otherwise you may fail in the final exam, and the person thinks I don't know why, they are also worried. So although it is a situation of worry, but the person is undervaluing that event. So this is minimization. Next cognitive distortion is personalization. So personalization, as the name says, person is self-referencing an external event without any basis of a connection. So person is personalizing an event onto himself. For example, a person thinks that my friend failed in an exam, okay, and because I couldn't give him the notes a day before the exam. So it may not be the reason of his friend being getting failed in the exam. Okay, it may be because he has not studied well. Okay, is not prepared well for that exam. But here the person is self-referencing that external event onto himself. This is personalization. And lastly, absolutist or dichotomous thinking. So again, here the person is thinking in two extremes. It is all or nothing thinking, or person is thinking everything as all black or as all white. For example, person says to his friend, you didn't pick my phone, you're worse even than an enemy. So here he's considering him to be even worse than an enemy, to one extreme. And on another instance, his friend helped him in the notes and he says like, you're my angel, you're everything to me. And now he's seeing everything good in that person. So either he is seeing everything, bad or everything good. This is absolutist or dichotomous thinking. Okay. So again, here the person is not, every one of us have both good and bad qualities. So person is not seeing that gray area, just seeing everything as all good or all bad. So this is absolutist thinking. So these were some important cognitive distortions. Now there is also a cognitive triad of depression given by Aaron Beck, which may be seen in patients with depression. So here patient, may have negative views about himself. So patient may think, that I am a very bad person, I am a bad son, or I am a bad husband, I am a bad mother, so I am worth nothing. So this is also known as worthlessness. Person may have negative views about the environment. People are not helpful, nobody can help me in this situation, so nothing can, help me to overcome. So they may feel, helpless. This is known as helplessness. And patients may also develop negative views about the future. They may say, tomorrow is very dark, very bleak, who has seen tomorrow? Tomorrow is, I can't see tomorrow. All bad things will happen tomorrow. So there is no hope for the future. So this is also known as hopelessness. So worthlessness, helplessness, hopelessness, these are cognitive triad of depression, which may be seen in depression. Now, second psychological theory is learned helplessness. So here this theory basically connects depression to the experience of uncontrollable adverse events. Okay, so there was an experiment in which dogs were given electric shock which they could not escape. So it was seen that after some time they would not even attempt to escape. Now when these dogs were put in another situation wherein if they would just cross a barrier, the shock would stop. But here, even in this situation, they would not try to even escape from the shock. So this is as if they have learned that they cannot control the external events and they have lost that motivation to act. Okay, similarly it is seen that patient with depression, they start believing that they don't have any sense of control of the external environment. Okay, and they start to lose the motivation to act. So this is, so they learn to become helpless. This is learned helplessness. Again, a psychological theory which is postulated for depression. Now, and fourth, factors are environmental factors. So many times certain negative life events or negative external events may also lead to depression. Okay, so life event which is most often associated with development of depression maybe in future is losing a parent before the age of 11 years. Okay, so this is the most common life event associated with development of depression. Okay, while the most often associated event which is associated with the onset of a depressive episode, that after this event the episode may occur, is loss of spouse. Okay, so such negative events again may lead to development of depression. Then there may be other environmental factors, one important being unemployment, which also again is seen to be associated with depression. So these were some important etiological factors of depression. Now let's talk about the symptoms of depression. How do we diagnose that someone is having depression or not? So someone, let us say, did not do well in the exam and the person was sad for a few days. So will we call it as a depression or a depressive disorder? So let us learn how to make a diagnosis of depression. Now, you can remember the symptoms of depression with the mnemonic SIGE CAPS. CAPS with double S. Okay, so let us learn the symptoms or understand the symptoms of depression. S is sad or depressed mood. Here the person is sad, and the sadness is not the normal sadness. So person is most of the time is sad. Okay, so whether it is morning, afternoon, evening, so most of the time the person is sad, and most of the places it is pervasive. Okay, so whether he's in office or whether he's in at home or whether he's outside, so generally the person would feel sad. So this is persistent and pervasive sadness. Then I stands for interest. So there is a decrease in interest in pleasurable activities. So for example, a 30-year-old female, she says, since 2 months she's appearing sad. and she reports that she is not finding interest in activities which she would enjoy before, like she does not enjoy going to for movies nowadays, does not enjoy going to kitty party, or even does not enjoy shopping. This is decreased interest. It is also known as anhedonia. Then next is G. G is guilt or worthlessness. Okay, so here the person has feelings of guilt, without any reason. Patient may feel that I'm a worthless person, I'm good for nothing, I'm a very bad person. So such negative feelings about oneself may occur in the patient. Then E stands for energy. Again, energy in the patient with depression is decreased. So they report that they get tired very easily. Okay, this is also known as easy fatigability. So patient says, even if I do half of work which I would normally doing, I feel tired. And sometimes even just by sitting only I get tired. So this is decrease in energy. This is SIGE. Then in caps, C is concentration. So patient often report that there is a decrease in concentration. So this is often many times the symptom, they come to us with the symptom of forgetfulness. That I forget where I have kept things, I forget when I'm talking to someone, in between I forget what was being talked about. Okay, so young patients may report of such forgetfulness. So this forgetfulness is not true dementia. Okay, it is because of the decrease in concentration, and once we treat the patient, this also improves. So it is not true dementia. So it is also known as, so you can correlate here itself, it is also known as pseudo dementia. And many times it is asked, pseudo dementia is seen in depression. Okay, then A is appetite. What happens to the appetite of a patient with depression? Again, majority of the patients say that there is a decrease in the appetite. I don't feel like eating. I've I eat half of what I was eating normally, and subsequently what is seen in the weight, there is decrease in the weight. But yes, some small proportion of patient may also report that there is an increase in the appetite. I'm eating more than normal. Okay, many times when we are emotional, we do a lot of emotional eating. We go to the fridge and start eating whatever is there. Okay, so some patients may also report of increase in appetite and subsequently increase in weight. So generally we say this significant weight changes when it is more than 5% of the weight in 1 month. Okay, so it can be decreased and it may be increased. Then P is psychomotor disturbances. So again, psycho means the mind, motor means the body activity. So the psychic activities and the bodily activities, again it may decrease. So patient, when you see such patient, they're moving very slowly, they're talking very slowly, so the psychic and the motor activities are decreased. Okay, so and many times it may be the opposite. There may also be psychomotor agitation. Many times patients with depression are very restless, they keep on moving around, they may not sit at one place, they may keep on speaking things. Okay, so it may again be reduced or it may be increased. Then S stands for, again, a very important symptom, suicidal thoughts or acts. So patient with depression may also have thoughts of ending their life. So suicidal thoughts, or they may also attempt suicide. So again, this may be seen. And lastly, there may be disturbances of sleep. Okay, so again sleep, many patients with depression report of decreased sleep, which is known as insomnia. Very characteristically, patients with depression report of early morning insomnia. Okay, so what is early morning insomnia? The patient report that they wake up 2 hours before their normal time. So patient says, normally I wake up at 8 o'clock, but nowadays I wake up at 6 or even 5 o'clock in the morning. Okay, so this may be seen in patients with depression. Also, there is a reduced REM latency. Okay, so basically whenever a person sleeps, person first comes to the NREM state, so non-rapid eye movement, and subsequently person reaches the first REM, rapid eye movement stage of sleep, and subsequently again there is NREM, then REM. This cycle keeps on going on in the sleep. Now time taken from NREM to the first REM is known as REM latency, which is normally 90 minutes. Okay, normally it is 90 minutes. So in depression, it is seen that there is a decrease in this REM latency. So the first REM is reached early. Okay, it may be reached early, maybe 30 minutes or even 60 minutes. So it may be reached early. So this is reduction in REM latency. Now again, here some patients, most of the patient may report of decreased sleep, but many patients may report of increase in the sleep. Okay, they may say that I'm sleeping more than usual, even during the daytime I'm sleeping more. So this is known as hypersomnia. Now also one important thing in decreased sleep or insomnia, it may be that the quantity is reduced. Okay, so patient may say I'm sleeping less hours, and sometimes patient may say that the quantity is fine but the quality of sleep is not good. Okay, so I'm sleeping normally, I would sleep for 8 hours, I'm sleeping for 8 hours, but when I wake up in the morning, I don't feel fresh. So this is denoted as decrease in the quality of sleep, which may be seen in patients with depression. So these are important symptoms of depression. So as you can appreciate, in such disorders, a lot of biological functions or vegetative functions are affected, like sleep, appetite. These are biological or vegetative functions, they are affected. Okay, now let us learn how to make a diagnosis. We have seen the symptoms which may be seen in depression. Now according to DSM-5, 5 or more symptoms should be, out of these 5 or more symptoms should be present. Okay, now and at least one symptom should be from the first two, that is either the mood is sad or there is a decrease in interest. Okay, at least one of the symptoms should be there, and total of 5 or more symptoms should be present for a duration of 2 weeks, that is for at least 14 days. If the symptoms are present, then we say that a person is having depression. And same in ICD-11 as well, they say it is 2 weeks. So let us say there is a patient who is reporting of feeling of sadness most part of the days. There is decrease in activities which the person would enjoy before. Okay, the person is reporting that I'm feeling very tired, the energy levels are very low, I'm forgetting things, where I've kept important documents, important keys, or I forget while I'm talking in between what was being talked about. And also reports of decrease in sleep, waking up 2 hours before the normal time. So this is a typical case, and the symptoms the patient reports is for at least for now 2 months. So if you can see the symptoms, describing symptoms of depression, and duration again is more than 2 weeks. So what is the diagnosis? The diagnosis is depression. This is how characteristically a patient with depression may come to us. Now there is something known as recurrent depressive disorder. Okay, so as the name suggests, recurrent, that means if there are 2 or more episodes of depression, if a person comes with 2 or more episodes, we say it is recurrent depressive disorder or major depressive disorder recurrent type. Okay, now suppose let us say a patient comes to us, okay, with symptoms of depression. Okay, and the patient, when you take a history, the patient says, yes, I had a similar episode when let us say 1 year back. So this is the second episode with which the patient has come to you, and patient had a another depressive episode in the past. So this is known as recurrent depressive disorder. Now one important thing is the minimum duration of normal period between 2 episodes should be at least 2 months. Then we will consider it as a separate episode. Let us say I'm treating a patient, since 1 month patient is having symptoms. Okay, treatment is started, and for 10-12 days patient is showing improvement. But again the patient reports that the symptoms have again they have increased, and the symptoms are again back to normal, the similar symptoms. Now, so since the duration of normalcy of 2 months is not there, this is considered as a single episode. Okay, so 2 months normal period should be there, that then only we call it as a separate episode. Now let's talk about an important topic in depression, the specifiers. So we have made the diagnosis of depression. So let us say in a patient we have made the diagnosis of depression. Now certain times the patient with depression may have certain unique features. So we add a specifier that this patient is having depression with whatever features, extra or unique features the patient is having. So let us discuss some of these important specifiers. First is with psychotic features. That means a patient has developed an episode of depression, and along with this now the patient has developed delusions or hallucinations. Okay, so this we call as depression with psychotic features, or sometimes we also call it as psychotic depression. Okay, now let us talk about these psychotic symptoms again can be mood congruent. That means the content of these symptoms, psychotic symptoms, is consistent with the theme of depression. Let us say a patient is having depression and the patient says that I'm dead from inside, people around me are dead, okay, or this world is dead. So what is this? This is delusion of nihilism. Or patient says I am a sinner, I have done lots of sins, and he's this this belief is up to a level of delusion. So this is what? This is delusion of guilt. So if you can see, these delusions are consistent with the themes of depression. Okay, or a patient may say that I'm hearing voices which are telling me that I should die because I'm a bad person. So again, even these hallucinations, they're consistent with the theme of depression. So this is mood congruent psychotic symptoms. While some patients may also have mood incongruent psychotic symptoms, where the content of delusion or hallucination is inconsistent with the themes of depression. For example, patient is having depression and the patient says that I am the king of the world, I am the richest person. Okay, so this is what? This is delusion of grandiosity. So mood incongruent psychotic symptoms may also occur. Now let us discuss three important scenarios. So this will be very helpful to understand three important disorders. Let's discuss them. So let us say we have patient A, B and C. Okay, now in patient A, let us say this patient is having delusions and hallucinations which have been let us say are occurring since 8 months, and also there is a brief period of depressive symptoms like sadness, decreased interest for 2 weeks in between. Okay, this is patient number A. Then patient number B has delusions and hallucination again for a duration of 8 months, and nearly for the same duration the patient is also having depressive symptoms. In between, maybe let us say for 2 weeks there were only psychotic symptoms and there were no mood symptoms. Other than that, if you compare the entire 8 months duration, nearly both the symptoms have been occurring together. And then we have patient number C, who started with symptoms of depression. Okay, and again for a very short duration the patient also has delusions and hallucinations. So let us try to understand what is the diagnosis of each of these patients. So what is the diagnosis of patient number A, where predominantly patient has delusions, hallucinations? And if you remember, schizophrenia, patient has 2 of the 5 symptoms, patient is having delusions and hallucination. Okay, and more than 6 months. So what is the diagnosis here? Schizophrenia. So patient with schizophrenia, yes, can have mood symptoms in between, and we have discussed in schizophrenia that presence of mood symptom is a good prognostic factor. Now let's talk about the second patient number B. Patient is having schizophrenia symptoms and mood symptoms. Here is a depressive disorder which is simultaneously present together throughout the illness. Okay, so what is the diagnosis here? It is schizoaffective disorder. Okay, this is schizoaffective disorder. While patient number C, predominantly there are depressive symptoms, and in between patient has psychotic symptoms. We have discussed, yes, patient can have psychotic symptoms. So this is depression with psychotic symptoms. Okay, and if you can see here, we have discussed when we talk about schizoaffective disorder that a 2-week period in between should be there when patient is just having psychotic symptoms like delusion and hallucination. So this help us differentiate it from depression with psychotic symptom, because in depression with psychotic symptom, patient will have depressive symptoms predominantly. It will start with depressive symptoms. Okay, so this is how Again, very, very important how clinically we can differentiate each of these three entities. Okay. Now, again, when we talk about, these specifiers, so this first specifier which we discussed, so we've discussed, how to make a diagnosis, and also, what is the importance, again, it is also helping us in the management. So when we talk about treatment of depression, we will discuss, we'll treat it with, drugs and also with therapy, and the drugs are antidepressants. But here, the patient, along with antidepressants and psychotic symptoms are there, even antipsychotics will be added. And many times, again, ECT is also shown to be, effective in such patient. But of course, we will, first prefer antidepressants plus antipsychotics. Okay. Also, in ICD-10, the specifier for psychotic feature was only for severe depression. So basically there is mild, moderate and severe depression. Mild depression is when, the person is just fulfilling the criteria, the symptoms are not very severe, the functioning of the patient is not very much affected. So patient may be, doing the activities, the functional impairment may not be very severe. While in severe depression, there are many symptoms, more intense symptoms, and the functional impairment is more impaired, significantly more impaired, and moderate would be in between. So ICD-10 used to say that, add this specifier of psychotic symptom with severe depression, but ICD-11 has made some changes that it says that even in moderate as well as in severe depression, we can add this specifier. Now, second specifier is depression with melancholic feature. Okay, and this is sometimes also known as involutional melancholia or melancholic depression. So this basically, is related with more severe form of depression. Okay, and it was usually, seen in, a lot of, elderly patient. Yes, it can be seen in younger, but more, it was seen in elderly patient. So it is more severe form of depression. So since it is more severe type of symptoms will be seen. So there is loss of pleasure to nearly all activities. So in melancholic features, patient, even day-to-day activities, normal activities also, the person does not find any pleasure. Okay, and there is a lack of reactivity to, all the pleasurable stimuli, even the small pleasurable stimuli, patient will not find, would not react to those stimuli. So there is a lack of reactivity in nearly all the pleasurable stimulus. Somebody comes to meet him, even those small pleasurable activities would seem to be, patient would seem to be not reacting. Okay, then there is a distinct quality of mood. The depressed mood is very, very severe. There is a profound despondency or despair, or patient will report of empty mood, severe misery from inside. Okay, so mood is very, very severely depressed. Again, early morning awakening. Okay, so the biological symptom may be significantly affected. Okay, again, weight, appetite again may be affected. So patient may report of anorexia, weight loss. Mood may be worse in the morning. So patient wakes up and says the mornings are very, very difficult for me. Okay. Then again, very importantly, patient may report of excessive guilt. Okay, out of proportionate guilt. Okay, maybe there. Again, many times, when they talk about melancholia, they may use these terms. Okay, and psychomotor disturbances, especially retardation, may be classically seen in such patients. Okay, so this is melancholic features. Again, importance again, in depression, we learn that, there is an increased risk of suicide as compared to general population, and risk may be even higher in patients who are having melancholic features. So one has to be very careful when we see such patients. Okay, and at times, it was seen that many a time, SNRIs, we'll talk about these drugs. SNRIs were seen to be, very effective for melancholic feature. But again, we don't say that, we recommend SNRIs again, because we will talk about this. SSRIs usually are the first drugs. But again, many studies have seen that patient with melancholic depression may have, more response, better response with SNRIs. The next is patient with atypical features. So now here, the patient is having certain, features which typically are not seen in depression. They are atypical features, so less or uncommon in depression. Okay, so generally, let me give you a mnemonic to remember these symptoms. So usually, typically if I ask you what will be the willpower of a patient with depression, typically patient will be will be low willpower. So since it's atypical, you can remember it like this. So patient says my will is high. So to remember the symptom, you can remember it with this mnemonic. So let's talk about the symptom. M is mood reactivity. So here the mood is reactive. Normally in depression, the mood is not that much reactive. Here the mood is reactive. So person's mood brightens in response to a positive event. So you take the patient to a party, the patient mood may brighten up. Okay, someone comes and meet the patient mood may brighten up. So mood reactivity is C. Then W is weight. So again we've seen typically we've seen that there is decrease in appetite and decrease in weight. Since it is atypical, so weight is increased and there is an increase in appetite. Okay. Then I again is very interesting. I is interpersonal rejection sensitivity. So interpersonal means between relationships. Okay, so interpersonal, patient is very extremely sensitive to rejection. So they're very sensitive to events, and even neutral things may hurt them. Okay, so interpersonal, they may have a long standing pattern of this interpersonal rejection sensitivity. And another interesting symptom is L is laden paralysis. Okay, so laden paralysis means the extremities, the arms, the legs, they would feel very heavy. So patient may report, as if these are laden with something very heavy, and person may report of not able to move because they appear very heavy. So this is laden paralysis, which may be seen in patients with depression. Then H is high. Again, H is hypersomnia. Normally we've discussed that what happens to the sleep generally is decreased, and sometimes in some small proportion of patient it may be increased. So here, since it is atypical, the patient may report of hypersomnia. There is increase in the sleep. So these are the symptoms of atypical features. Now again, in the treatment, they respond well to antidepressants like SSRIs, MAO inhibitors, monoamine oxidase inhibitors, and drugs like bupropion. And they don't have, they don't show good response to drugs like TCAs. TCAs are tri- and tetracyclic antidepressants. They generally don't respond well. So again, these may also, affect our decisions in the management. So this is atypical features. Next are depression with catatonia. So we've learned, so catatonic symptoms like mutism or excitement, waxy flexibility, posturing, negativism, echolalia, echopraxia, these are catatonic symptoms. And again, we have discussed, when we discuss in schizophrenia, catatonic symptoms can be seen in other conditions. In fact, catatonic symptoms are more common in mood disorders than even schizophrenia. So patient with depression may also have catatonic symptoms, and again it will also affect our treatment strategy. Again, because of catatonic symptom, we have to give drugs like lorazepam, maybe initially IV, and sometimes ECT may be given, of course, along with antidepressants. So again, patients, in the question, if they ask, having depression with catatonic symptom, what will be your treatment? Of course, you will add, also antidepressant. But if you have to choose one, again, you have to, choose, because maybe they are asking, what will be the treatment for these catatonic symptoms? Okay. So again, it is also affecting our management. Then next specifier, or the fifth, specifier is depression with postpartum onset, or also known as postpartum depression. So basically, a patient, a female having depressive symptoms in pregnancy, or within 4 weeks, okay, 4 weeks of delivery. Sometimes it may be seen up to 3 months of delivery, but usually again in the guidelines they say up to 4 weeks of delivery. If a female develops depressive symptoms, it is known as postpartum depression. DSM-5, since it is also during pregnancy as well as within 4 weeks of delivery, DSM-5 uses this term peripartum onset. Okay, so again, because of changes in the body, there are physiological endocrinal changes, also there are social responsibility, and so many other factors may again predispose to development of a depressive episode. Again, we'll discuss or talk about this we'll talk about postpartum blues, postpartum depression, and postpartum psychosis in the end of this session. Okay, so this is another specifier. Now depression also, it's an older way of classifying. Nowadays we don't use this classification very often, but there was an older way of classifying depression as endogenous and exogenous or reactive depression. So as the name suggests, in endogenous depression, the cause used to be more of biological factors. Okay, like we have discussed, neurotransmitters, endocrinal systems, a lot of biological factors would play a role, and generally there would be no precipitating event. Okay, there would generally be no negative adverse effect related with this endogenous depression, and a lot of time patient may have melancholic or psychotic features. While when we talk about exogenous, the cause is generally more of psychological factors, may play a more important role. Precipitating event like a negative life event, like death of a close one, or maybe losing a job or some kind of such stressor may be there. And patient, along with usual symptoms of depression, may also complain of a lot of somatic complaints. There is pain, headache, abdominal pain, or other such somatic symptoms may be present. So it's an older way of classifying depression. Now talking about suicide, we've seen that in depression 10 to 15% of the patients, they commit suicide, and again suicide is higher than general population if we compare it with patients with depression. And most common psychiatric disorder associated with suicide again is depression. So we've discussed symptoms. Now sometimes there are also certain physical signs which may be seen in patients with depression. So one of the physical signs is Variegat's fold. It's a triangular fold in the nasal corner of the upper eyelid. If you can see in the diagram here, so this is Variegat's fold, and it occurs because of changes in the tone of the facial muscles like the corrugator or the zygomatic muscles. Because of chronic changes in the tone of these muscles, Variegat's fold may be seen. Another physical sign is the omega sign. It's an omega shaped fold. It is seen on the forehead above the root of the nose. Again, you can see in the diagram. This is basically omega sign. Okay. Again, it is because of excessive use of corrugator muscle. So these are some of the physical signs which may be seen in patients with depression. Now there are certain poor prognostic factors. So certain factors, if present, they generally are poor prognostic factors in depression. Okay, one of them being comorbid dysthymia or comorbid dysthymic disorder with major depressive disorder. So we'll talk about what is dysthymia. It's a milder form of depressive symptoms which occur at least for continuously 2 years. So along with this, if patient has depression, again it seems to be a poor prognostic factor. Again, comorbid substance use, substance use disorders like tobacco, alcohol, if they are present, again these are signs of poor prognosis. Presence of comorbid anxiety symptoms, many times anxiety symptoms may be present with depression. If there is more than one previous episode, so recurrent depressive disorder, again it's a poor prognostic factor. And again, gender being male, again is a poor prognostic factor. So good prognostic factors are if there are mild symptoms, no psychotic symptoms, less no need for hospitalization, female gender, these are some good prognostic factors. So these are some poor prognostic factors in depression. So nowadays a lot of talk is about prognosis. So prognosis is basically outcome. So you can remember some of these factors. Now let's talk about the treatment in depression. Again, depression treatment has two main pillars. One is the pharmacotherapy, which is the drugs, and the other is psychotherapy. Okay, we'll talk about them one by one. So let us talk about first pharmacotherapy. Now in pharmacotherapy, the main treatment for depression are the antidepressants. So we'll talk about some of the important antidepressants. Okay, now usually we say all these antidepressants may take 3 to 4 weeks for the onset of action. Okay, but yes, of course, so this is theoretical, but of course clinically we may sometimes see some improvement, or the onset may be in 1 to 2 weeks, but theoretically it is around 3 to 4 weeks. Okay, and also these are chosen according to the side effect profile. So many of these drugs may have similar efficacy, but the drug we choose for the patient is based on the side effect profile, which drugs have lesser side effects, and they have better tolerability. Those drugs generally are preferred. Now, the duration, generally we say that once we start the treatment, for duration we give it for at least 6 months. So once the patient has shown improvement, so we maintain that drug for at least 6 months, or the length of previous episode. So what was the length of previous episode? So again, it may be 6 months or the length of previous episode, whichever is greater. For that much duration at least we continue the treatment. Now also there is a concept of maintenance or prophylaxis. Sometimes we give medicines to prevent the future episode. Okay, so we may give drugs, and generally in which cases, situations we prefer prophylaxis or maintenance. If there are 3 or more episodes of depression, so someone has 3 or more previous episodes, in those cases we can think of prophylaxis. And if someone has chronic depression is when the symptoms are present for more than 2 years. Generally we have discussed depression is an episodic illness, okay, but sometimes in certain cases it may continue for more than 2 years. That is known as chronic depression. In again such cases we may choose maintenance or prophylaxis. Now, the first important drug are the SSRI, that is selective serotonin reuptake inhibitors. So these are basically considered drug of choice. These are considered drug of choice. Again, based on the safety profile, we choose SSRIs as the first line drugs for depression. Now, some of the important SSRIs include sertraline, fluoxetine, paroxetine, citalopram, escitalopram, vilazodone, and fluvoxamine. Okay, so these are some of the important SSRIs. Now, escitalopram, we say, escitalopram, it is the most serotonin selective drug. Okay, it is the most serotonin selective drug. Vilazodone, vilazodone again, which is, we are keeping it under SSRI. In fact, it belongs to, it is a SPARI, drug. That is, it is a serotonin partial agonist and reuptake inhibitor. So yes, it has SSRI property. It also is a 5-HT1A partial agonist. Now, fluvoxamine, which is a SSRI, this is one drug which is not used for depression, but it is, used for OCD. So we'll again discuss when we talk about OCD. Okay. Now, as the name suggests, selective serotonin reuptake inhibitor, these drugs basically are preventing the reuptake of serotonin from the synapse. So basically, they are increasing the serotonin level, and we have discussed in the etiology that the serotonin levels are decreased. So this way also you can remember the etiology. So SSRIs are basically increasing the serotonin level. So in the etiology we know the serotonin levels are decreased. Now, let us talk about some important side effects of these SSRIs. Now, there are GI side effects. Nausea is the most common GI side effect. Then it can cause diarrhea. There may be anorexia. There can be dry mouth. Please remember, dry mouth is a side effect. Okay, there was a question in the exam there in which you have to choose which of the following is not a side effect, and there was hypersalivation. No, there is dry mouth. Also, sometimes constipation can be seen, especially with paroxetine. Paroxetine has anticholinergic properties, so that can lead to constipation, and even weight gain may be seen with many of these drugs. Then there are CNS side effects. Patient may report of anxiety. There may be insomnia. Some again drugs can cause sedation. So accordingly, if the drug is causing sedation, we prefer it at the night. If some drug is causing insomnia, we may prefer in the morning. Then vivid dreams can be seen. Okay, sweating, emotional blunting. Patient is not able to experience emotion, so there may be emotional blunting. Seizures can be seen, and sometimes even extrapyramidal symptoms, although uncommon, may be seen with these drugs. Then there may be important sexual side effects can be seen. Sexual side effects, in fact, are the most common side effect with long-term treatment. Okay, so side effects like decreased libido, delayed ejaculation. This one side effect, especially, we use it, for premature ejaculation. Okay, so again, sometimes side effect may be used for the treatment of premature ejaculation, and also inhibit, it may inhibit orgasm. Then there are certain hematological side effects like, there is functional impairment of platelet aggregation. So especially, if you give, these SSRIs with NSAIDs, again, there is an increased risk of, bleeding. So sometimes, you should also add a, proton pump inhibitor as well. Then there are certain other miscellaneous side effects like, hyponatremia, again, especially with elderly population, you may, find hyponatremia, allergic rashes, and even hyperprolactinemia may be seen. So these are some important side effects with SSRIs. Now, there is something known as serotonin syndrome. Okay, so concurrent use of SSRI along with drugs like, MAO inhibitors. MAO inhibitors basically, they inhibit the degradation of monoamines like serotonin. So you're giving SSRI and you're giving MAO inhibitor, there is a increased surge of serotonin. Then with L-tryptophan, again L-tryptophan, increases the synthesis of serotonin, and even lithium, again lithium has some serotonin agonist activity as well. So concurrent use of these drugs with SSRIs can increase the serotonin concentration to toxic levels, which leads to certain symptoms which is known as serotonin syndrome. So it can lead to diarrhea, there may be restlessness, extreme agitation, hyperreflexia, autonomic again instability, there is fluctuation of blood pressure, autonomic instability is there. Then CNS symptoms like myoclonus, seizures, hyperthermia, rigidity, and if it is more severe then delirium, coma, cardiovascular prolapse, and even death can occur. So a patient on SSRI with these symptoms, especially like diarrhea, hyperreflexia, myoclonus, these symptoms suggest that there is serotonin syndrome. Now, in the treatment generally, again supportive care is necessary. Supportive care is there, and cooling, again cooling is important. There is hyperthermia, and again drugs like cyproheptadine, which are serotonin antagonist that can be used. Then there is a syndrome known as discontinuation syndrome. As the name suggests, discontinuation syndrome basically because of abrupt discontinuation, so it leads to certain withdrawal symptoms. Okay, so this is discontinuation syndrome, and generally these are more seen with shorter acting drugs like very commonly especially with venlafaxine. Okay, drugs which have shorter T-half, fluvoxamine, paroxetine, these are the drugs again which are known to be associated with discontinuation syndrome, and generally it is generally not seen with drugs which are generally longer acting. Fluoxetine is one of the longest acting of these antidepressants, so again less likely that it will be seen with longer acting drugs. So it is seen with shorter acting drugs. What are the symptoms which are seen in discontinuation syndrome? So you can remember it with the acronym FINISH. So there are flu-like symptoms like lethargy, weakness, headache is there. Then insomnia can be seen. N is nausea can be seen. Then there may be symptoms of imbalance like dizziness can be seen. Sensory disturbances like paresthesia, tingling sensations over the body can be seen. And hyperarousal symptoms like rebound anxiety, okay, or even irritability. So patient is being given medicine and there may be a rebound anxiety because of sudden abrupt stoppage. So these are symptoms which may be so basically for discontinuation syndrome you should not stop, especially the drugs which are short acting abruptly. So you should taper and then stop these drugs. Now another drug is vortioxetine. Vortioxetine, again it is a serotonin reuptake inhibitor like SSRI, but it has other, so it's a newer relatively newer drug. It has other mechanisms also. It is agonist at 5-HT1A, partial agonist at 5-HT1B, and antagonist at 5-HT1D, 5-HT3 and 5-HT7. So you can remember it like this. Okay, so it has other mechanisms of action as well. Okay, now SSRIs and pregnancy, many a times we have to give these in pregnancy as well. Now please understand they are not major teratogen, but one drug you should remember, PEEP for paroxetine, and P for paroxetine should be avoided in pregnancy. Paroxetine is shown to have certain cardiovascular teratogenic effects. So this is one drug you should definitely not give in pregnancy. Other SSRIs, if required, we weigh the risk and benefit, because a female having depression in pregnancy, again it may hamper the depression as a disease itself, may affect the baby, because again person may not take proper care, so we might have to treat. So sometimes we see the risk and benefit. Now, SSRIs along with, to some extent, SNRIs, we'll talk about SNRIs, just in a while. So these drugs generally, especially if given late in pregnancy, they're known to cause, persistent pulmonary hypertension of the newborn. Again, the incidence is not very high, and also it is manageable, after the birth. So again, but yes, it can cause this. Now there are, certain studies, again, these are not very consistent findings. Many studies have shown there may be neurodevelopmental or motor disorders, ADHD or autism spectrum disorders may be seen, or low APGAR score, decreased gestational age or birth weight of the of the newborn, or even gestational diabetes or preeclampsia may be seen with these SSRI again. But as I said, again, very inconsistent findings. Smaller studies have only shown, so again, not very consistent finding. Second group of the antidepressants are the SNRIs. These are serotonin and norepinephrine reuptake inhibitors. So what are they? They are again increasing serotonin and norepinephrine. So they're inhibiting the reuptake. So they're increasing these levels. Again, we have learned that serotonin, norepinephrine are decreased. So again, you can remember the etiology through the mechanism of action as well. Okay. Now these are also known as dual reuptake inhibitors. Okay. Now again, in certain studies, again, it is shown that they may have better efficacy, in melancholic depression, which is a severe form of depression. So again, as we are seeing that two neurotransmitters, they are increasing, but still we keep SSRIs as the drug of choice. But of course, sometimes this point may be asked, so you can remember this. Now, some of the important SNRIs include venlafaxine, desvenlafaxine, duloxetine, levomilnacipran, and milnacipran. So these are some important SNRIs. Again, venlafaxine, desvenlafaxine, levomilnacipran, duloxetine, they are used for depression, okay, or for MDD. Duloxetine is, again, also useful for neuropathic pain associated with diabetes. Okay, so it's FDA approved for this condition. FDA is Food and Drug Administration in the USA. So it is approved it also for neuropathic pain associated with diabetes. Also it may be used for stress urinary incontinence. Now milnacipran in this category is not used for depression, but it is approved for fibromyalgia. Now side effects of SNRIs, again, they are similar to SSRIs, okay, like GI side effects or sexual side effects or CNS side effect. They are similar. Again, hypertension may also be seen, especially with higher doses of venlafaxine, okay, and somewhat even desvenlafaxine, but again, so it is again dose related. Maybe with higher doses it can be seen. Now let's talk about next category, that is the TCAs. These are tricyclic and tetracyclic antidepressants. Okay, so basically what they do is they block the transporters of serotonin and norepinephrine. So basically, again, they are increasing their levels. Okay, along with this, they also block certain other receptors. So they have a lot of other side effects because of blockage. So as compared to SNRIs, again, they have more side effects because it blocks other receptors, like their antagonism at muscarinic receptors. So anticholinergic side effect may be seen in H1 histaminic receptor, alpha-1, alpha-2 receptors, and also voltage sensitive sodium channel blockage may also be seen with the TCAs. So there are tricyclic and tetracyclic antidepressants. So some of these drugs you can remember. One is so you can remember with CAT, that is clomipramine, amitriptyline, and trimipramine. Okay, then DID, doxepin, imipramine, dothepin. Then DNP, desipramine, nortriptyline, protriptyline. Okay, so you can remember these drugs. And tetracyclines you can remember by MAM, maprotilin, then amoxapine, and mianserin. Okay, so these are some important TCAs. Now some individual points about some of these drugs. Now clomipramine, if we see, clomipramine is the most serotonin selective. Okay, so they increase both serotonin and norepinephrine. Clomipramine is the most serotonin selective, and it is also used for the treatment of OCD. So in OCD, we'll talk about OCD. SSRIs are the first line drug. One of the TCAs, clomipramine, is also approved for OCD. Then imipramine is used for treatment of nocturnal enuresis. But drug of choice is desmopressin, and treatment of choice, for nocturnal enuresis is basically behavioral technique like bell and pad, alarm system. That is, the treatment of choice. But yes, imipramine can be used. Then next is desipramine. Desipramine is the most norepinephrine selective. Okay. Then amoxapine, which is a tetracyclic antidepressant, TCA. It also blocks D2 receptors. So D2 receptors, blockage we have discussed, in schizophrenia, antipsychotic property. So it blocks D2 receptors as well. So similarly, side effect may also be similar, which we will discuss. Then there is one bicyclic antidepressant. For you, just for your psychopharmacology knowledge, you can remember there is a bicyclic antidepressant which is viloxazine. Okay. Now, coming to the side effects. So as we've discussed, it blocks, certain other receptors. So there are certain side effects also. So one is again anticholinergic side effects like dry mouth, delirium, constipation, blurred vision, urinary incontinence. Again, these can be seen because of blockage of the muscarinic receptor. So again, they should be avoided in especially narrow angle glaucoma. It can exacerbate the symptoms, and also in prostate hypertrophy. They should be avoided. Then cardiac side effects may also be seen, like tachycardia is there, flattened T waves, prolonged QT interval, ST segment depression, and even arrhythmias. Arrhythmias can be seen, and especially arrhythmias because of the voltage sensitive sodium channels are blocked at higher doses. Again, arrhythmias can be produced. Then other side effects like neurological side effects may be there. So tremor, fine tremors, rapid tremors may be seen. Seizures again can be seen again at higher doses. Again, it is again because of the blockage of the voltage sensitive sodium channel in the brain. So at higher doses, it can lead to seizures. Then again, amoxapine, as we have discussed, it also blocks the D2 receptors. So again, it can also lead to especially side effects like EPS. Then galactorrhea, even gynecomastia may be seen with certain TCAs. Again it can be seen especially with amoxapine. Okay. Then autonomic effects, again, as we have discussed, alpha 1 alpha 2 blockage is there. So there may be postural hypotension, and again sedation, weight gain, again they can be seen especially because of blockage of the histaminic channel, histaminic receptor. So again, you can correlate with the blockage of certain receptors which TCAs block. So you can see, so it has lot of side effects also. So that is why TCAs are not preferred drug of choice. Okay. Now coming to the TCA toxicity, again especially in depression, sometimes patient has suicidal thoughts. Patient may take a lot of medicine together. So again, risk of toxicity is there. Now in TCA toxicity, there may be CNS symptoms like altered sensorium. There is respiratory depression, again seizures, as we had discussed, because of blockage of the sodium sensitive, voltage sensitive sodium channel in the brain. Then serious side effects like hypotension. On ECG, there may be increased PR interval, QRS, QT interval again is increased, AV block or right axis deviation. QRS, more than 100 millisecond again is the basis for the management. We'll talk about it. Then ANS may be affected, again autonomic nervous system may be affected, dry mouth, again blurred vision, urinary incontinence. These symptoms can be seen. Now so there is basically metabolic acidosis is seen, which is secondary to the tissue hypoxia because of cardiovascular abnormality and because of the seizure. So there may be tissue hypoxia leading to metabolic acidosis. Now in the treatment especially when the QRS interval is more than 100 millisecond, it is the basis. So what is the treatment at that time? So what is the treatment? We give IV sodium bicarbonate. Okay, basically serum alkalization is done. So again, this is important. Okay, so this is TCA toxicity. Next category of drug are the monoamine oxidase inhibitors, or also known as MAO inhibitors. Okay, these were the first class of antidepressants which were approved, and they basically inhibit the metabolism of monoamines like serotonin, norepinephrine, dopamine. So they're increasing the levels. Okay, so again now MAO enzymes, there are two types: MAO A, which metabolizes all these three, that is serotonin, norepinephrine, and dopamine, and MAO B, which is involved in the metabolism of only dopamine. Now again, there are various types of these MAO inhibitors. One are the non-selective MAO inhibitors, okay, which are phenylcypromine, isocarboxazid, and phenelazine. Then there are reversible inhibitors of MAO, also known as RIMA. Okay, there is one important drug, moclobemide. Okay, then there is also selective MAO-B inhibitors, salazilin and rasaglilin. Okay, so these are some important MAO inhibitors which you can remember. Now, there is interesting cheese reaction. There is important cheese reaction, or known as tyramine induced hypertensive crisis. Okay, so cheese reaction is associated with MAO inhibitors. Okay, so basically people who consume, cheese, beer, fish, or substance like red wine, which is contains tyramine. Okay, and tyramine basically is a sympathomimetic which is metabolized in the GI tract. Now, MAO inhibitors basically, so someone is taking MAO inhibitor and he consumes one of these substances which are rich in tyramine. So what happens is MAO inhibitors, they inhibit the tyramine metabolism. Again, it has sympathomimetic activity, so it enters the circulation, and again it can lead to hypertensive crisis. Already there is increased levels of these neurotransmitters like norepinephrine because of MAO inhibitor, and again this tyramine has also entered the circulation, which leads to hypertensive crisis. And again treatment is phentolamine, which is a alpha antagonist. So this is cheese reaction associated with MAO inhibitors. These were the certain typical antidepressants which were increasing the these neurotransmitters. So they had similar, so they are known as typical antidepressants. Now we have certain atypical antidepressants which have somewhat slightly different mechanism of action. So let us talk about some of these important atypical antidepressants. So first is a SARI drug, which is serotonin antagonist and reuptake inhibitor. So it's an antagonist as well as reuptake inhibitor. So it is antagonist at 5-HT2A and 2C. Okay, and also it is working like a SSRI. So it is basically inhibiting the reuptake. So drugs here in this category include trazodone. Okay, trazodone again, it has it causes a lot of sedation. So sometimes it is used in treatment of insomnia. So especially patient with depression having insomnia, again trazodone may be used. One important side effect is it can lead to prolonged erection, which is painful, priapism, which can be seen with trazodone. Now another drug is nefazodone. Again, nefazodone is not much used these days because it is hepatotoxic. So these are SARI drugs. Then next is the NASA drug. Okay, these are noradrenergic and specific serotonin antidepressants. So what are these drugs? So they increase norepinephrine and to some extent even serotonin because of antagonism at the central presynaptic alpha-2 receptors. Okay, when it is occurring as a antagonist at the presynaptic level, it increases norepinephrine, and it is also specific serotonin antidepressant. It is antagonist at postsynaptic 5-HT2 and 5-HT3 receptors. Okay, so this is NASA group of drug, and one important drug you can remember here is the mirtazapine. Okay, now mirtazapine has an important side effect. Again, most common side effect is again it can cause sedation. Okay, weight gain also is there. Now generally sexual side effects which we have discussed with drugs like SSRI, SNRI, again they're uncommon, not usually not seen. So one of the drug with least sexual side effect, again you can remember, so mirtazapine. Next is NDRI. Okay, NDRI, what is NDRI? It is again norepinephrine dopamine reuptake inhibitor. So it is now inhibiting the reuptake of norepinephrine, so increasing norepinephrine and also dopamine. So we have discussed even dopamine is also decreased, so it is increasing that. So one important drug in this category is bupropion. Again, bupropion has low risk of sexual dysfunction or sedation or weight gain. Again, as you can see, because it does not affect the serotonin levels that much. Okay, so again these side effects are less. Common side effects with this may be insomnia, tremor, nausea, dry mouth can be there. Now seizure is an important side effect, especially at higher doses. So again, bupropion should not be used someone who is at risk of seizure. Okay, so again you can remember one important side effect is the seizures. Also bupropion is an antidepressant which is used for smoking cessation. Okay, it is used as an anti-craving agent in smoking cessation. So antidepressant for smoking cessation, it is bupropion. Then next is the NSRE. Okay, it is a norepinephrine serotonin reuptake enhancer. Please see, it's an enhancer. Okay, so again it has a different mechanism of action, and the drug here is tianeptine. Okay, then another drug is ameneptine. Ameneptine is again dopamine reuptake inhibitor, as well as again it is also an enhancer and also a norepinephrine reuptake inhibitor. Okay, so these were some important antidepressants. Now there is another novel agent which is S-ketamine. It is an S enantiomer of ketamine. Mechanism of action is basically it is N-methyl D-aspartate, that is NMDA antagonist. Okay, basically NMDA is basically glutamate receptor, so basically it is affecting it is a glutamate modulator. Okay, route is basically it is given through nasal route. Okay, it is given for through nasal spray, and it is approved by the FDA in 2019 for one very specific condition, that is treatment resistant depression. So what is treatment resistant depression? So as the name suggests, someone who is not showing improvement with at least 2 different class of antidepressant. Okay, so along with this, in conjunction with oral antidepressant, S-ketamine can be added. It can be added. So again, it's a little newer drug, so you can remember S-ketamine. Now again, S-ketamine, because of the risk of abuse. Okay, again, ketamine, is also abused. So again, S-ketamine may be abused. So it should, self-administration under supervision of the doctor. Okay, so it should not be given to the patient. It should be administered, in front of the doctor. And the patient should be, at least observed for 2 hours after administration, because of side effects like sedation, dissociation, again, which can also be seen with ketamine. So it can occur here also again. So patient should be observed for at least 2 hours after the administration. Now, after these, antidepressant, then there are certain augmenting agents. So augmenting agent means that these drugs in itself don't have an antidepressant, effect, but they augment the effect. So along with antidepressants, sometimes we can add these drugs to improve the symptoms. Okay, so drugs like lithium again is an augmenting agent, can be used. Atypical antipsychotics like Qutipin, aripiprazole, and other atypical antipsychotics, they can be used. And again, as we had discussed, even thyroid hormone may be used as an augmenting agent. Again, not thyroid hormone is not very clinically commonly used. These above drugs may be more commonly used. Okay, so these are some important augmenting agents. Now the one pillar was the drugs. Now the another pillar of treatment is the psychotherapy. So basically psychotherapy means treatment using certain psychological methods. One important psychotherapy for depression is the cognitive behavior therapy, or CBT. This has the best evidence. So out of all the therapies, it has the best evidence. So basically, as the name suggests, we use cognitive techniques and behavior techniques. So as we had discussed, in psychological theories, there are cognitive distortions are there. So cognitive distortions are corrected. So we try to correct the cognitive distortions through the cognitive techniques. And there are also a lot of maladaptive behaviors which are seen. So through the behavior therapy, we try to correct those behaviors. Okay. Now, then other therapies include interpersonal therapy. So as the name suggests, interpersonal, between relations. So it focuses on patients' current interpersonal problems, relationship problems with the family members, so that it focuses on the interpersonal problems, again, which may be a factor in precipitating or maintaining depressive symptoms. So we try to correct those relation problems. Then there are other therapies like again family therapy, involving the family, psychoeducating them, trying to help the patient. Then psychoanalytically oriented therapies, using psychoanalysis and psychoanalytical techniques, again they can be used, and even behavior therapies can be used. So these are some other therapies. Now when we talk about, so we discussed drugs, we talked about therapy. So when we talked about what is the treatment of choice, now theoretically again, in studies, it is seen that combination of both drugs and therapy has shown to be of higher efficacy. But again, in clinically, single therapy alone is sometimes sufficient for most of the cases. Okay, so it may not be that in all the cases you have to combine. Okay, so single therapy we have seen, either drugs or therapy may be effective, especially if the patient has milder symptoms is, that is, the symptoms, only it is fulfilling the criteria, the intensity is not very high, as well as the functional impairment is not that much. In such cases, you may start with therapy like CBT. But if the symptoms are moderate or severe, if the symptoms are moderate to severe, then again, of course, drugs may be, drugs should be started, and along with this, if required, you may add therapy like CBT. Okay, and drug of choice, we have discussed the SSRIs. Then there are other certain somatic techniques, or methods which can be used. One of the methods is the electroconvulsive therapy, or ECT. So basically, patient, is given, anesthesia. So nowadays, any ECT we give is modified ECT. It is under anesthesia. We put electrodes and we pass an electric current. So electro means electric current is passed, and convulsions are produced, seizures are produced. Okay. So one of the important indication, this is again very important, is indication depression with suicidal risk. So any patient who comes to you with depression and he's having suicidal thoughts or is attempting suicide, again it's a psychiatric emergency, and there the preferred treatment will be ECT. So if you're asked, again, of course you may start drugs, therapy again, but these may take time. So at that time, if there is suicidal risk, please remember the preferred treatment is ECT. Even if, let us say, they give you a question in which patient is pregnant. Let us say patient is pregnant, along with this patient is having depressive symptom plus suicidal thoughts. Okay, again, what will be the treatment of choice? So there are suicidal thoughts, again the treatment of choice is ECT. Even in pregnancy we can give ECT. So don't think if it is pregnancy we cannot give ECT. Of course we have to monitor, we have to keep the gynecology and the the fetal monitoring has to be done, but again ECT is preferred. Okay, other indications, again, other than this, maybe severe depression with patient is having stupor, or psychotic symptoms are there, or depression with psychotic symptom. Again, there we give antidepressants plus antipsychotic, but again ECT may be also given. Then depression which is refractory to other modalities, so it is not showing improvement with other modalities, then we may also prefer ECT. And also, of course, we have discussed if there are catatonic symptoms, then also again one of the treatment for other than lorazepam is also ECT. Then next is transcranial magnetic stimulation, TMS. Basically here it uses small pulses of magnetic energy which stimulates the nerve cells. So basically we use RTMS. RTMS is a therapy which is used, which is repetitive transcranial magnetic stimulation. Here basically what happens is repetitive changes in the magnetic field leads to secondary electrical stimulation of certain cortical regions we try to stimulate. We have discussed there are certain neuroanatomical areas which are implicated, so we try to stimulate some of those areas. Okay, now some of the advantages of this RTMS over ECT is that it is non-convulsive. ECT used to produce convulsions. Now no anesthesia is required, while anesthesia was required in ECT. It has a safer side effect profile, and no cognitive side effect may be seen, while in ECT one of the side effect was amnesia, although that was transient. In ECT the side effect of amnesia is although transient, but there may be seen, but here there is no cognitive side effect. Now FDA has approved the use of this technique in patients who have failed to achieve satisfactory improvement from at least one antidepressant, then you may try RTMS. Okay, most common adverse effect with this is again scalp pain or discomfort. Now another technique is the vagal nerve stimulation, VNS. So basically here the left cervical vagus nerve, we put an electrode, okay, and then there is an impulse generator which is implanted on the chest, and intermittent stimulation of this vagus nerve through the electrodes, it is seen that most of the fibers of this vagus nerve are afferent fibers. They go to the brain and stimulate the serotonergic areas of the brain, so it increases the serotonin levels. Okay, so this is another modality which may be used. Okay, next is the deep brain stimulation. Now again in deep brain stimulation, Implantation of leads, again, it's an invasive technique. Leads are implanted in certain specific areas, okay, and then these areas are stimulated. Again, for chronic intractable depression, it may be used again, but it is not approved, FDA approved for, depression, till now. Again, it's in the research, research domain. Then phototherapy. Phototherapy again is an important modality. It's a light therapy for seasonal affective disorders. For seasonal affective disorders. What are seasonal affective disorders? These are mood disorders which have a seasonal pattern. So, again, it is seen depression is more common during the winter times. So, somebody is having at least 2 depressive episodes in the last 2 years during the winter season, and there is no other non-seasonal, episode has occurred. So, again, it is suggestive it's a seasonal affective disorder. So, generally, bright light in the range of 1500 to 10,000 lux or more is used. So, basically, a light box is put, in front of the patient, and the patient is exposed to it for at least 1 or 2 hours every day. Okay, so light therapy, especially for seasonal affective disorder, again can be used. Then sleep deprivation, again, another technique, significant but transient benefits have been seen. So sleep deprivation, as the name suggests, patient is deprived of, sleep, and is shown to, to have improvement again, but positive results usually reverse by the next night of the sleep. So when the person, sleeps the next night, so the improvement may be reversed. Again, in the research domain, again, studies have been conducting on this sleep deprivation. So these are some other somatic methods which may be used in the treatment of depression. Now let's talk about bipolar disorder. Now, in bipolar disorder, what happens? There are episodes of mania, depression, hypomania, or even mixed episodes. Okay, so patient has episodes of these, that is known as bipolar disorder. Now, there is bipolar 1 disorder, in which patient has at least 1 episode of mania and at least 1 episode of depression, that is known as bipolar 1 disorder. Then bipolar 2 disorder is when patient has at least 1 episode of hypomania and 1 episode of at least, depression, then that is bipolar 2 disorder. Now, please remember, even a single episode of mania is now also considered as a bipolar disorder. So these are included in bipolar disorder. Now, earlier in ICD-10, it was not classified as bipolar 1 and 2, but in ICD-11, just like DSM-5, they have included 2 types of bipolar disorder, that is bipolar type 1 and bipolar type 2. Okay. Now, let's try to understand before, starting with the symptom, let's try to understand what are these bipolar disorders. So suppose a patient has an episode of, depressive symptoms fulfilling the criteria of depression. We say it is depression. Okay, so this is what? This is an episode of depression. Now, let us say patient has another episode after a few months, let us say. So then what will be the diagnosis? The diagnosis now will be recurrent depressive disorder. Okay, so these we have already discussed. Now, suppose a patient has a hypomania. So, if you see the diagram, in this here, this is the threshold. If the symptoms are touching, it is fulfilling the criteria of depression. Here, if this is, the patient is touching this line, that means he's fulfilling the criteria for hypomania. We'll talk about what is hypomania. And if the patient is touching this line, that means he's fulfilling the criteria of mania. Okay. So here in this case, again, patient has already had 2 episodes of depression, and now patient has come with an episode of hypomania. So now what will be the diagnosis? It is bipolar 2 disorder. Current episode is hypomania. Okay. Now, let us say now this patient after some time again comes to you with an episode of mania. Now what will be the diagnosis? Now if you can see, the diagnosis is changing. Okay, depending on what episode the patient is having. Now the diagnosis is bipolar 1 disorder with current episode mania. Okay, because there is at least 1 episode of mania and at least 1 episode of depression is there. It may be any number, at least one episode, then now it is bipolar 1. Okay. Now, please remember, even if after this patient may have any number of hypomanic episodes, it will still remain bipolar 1 disorder because patient has had at least 1 episode of mania now. Okay. So this is how we make the diagnosis of bipolar disorder. Okay. Now, coming to the epidemiology, the prevalence of bipolar disorder is 1%. Now, when we talk about bipolar 1 and bipolar 2 disorders, male to female ratio in bipolar 1 is the same, nearly the same, while bipolar 2 female is more than male. Again, mean age of onset is bipolar 1 disorder is around 30 years. In fact, although at times, the symptoms may start in the 20s, but mean age we say is 30 years. And bipolar 2 is slightly higher age, okay, slightly higher age. But as you can appreciate, mean age in depression was 40 years. So it is earlier than depression. And again, more commonly seen in patients who are divorced or single or separated. Now, coming to bipolar 1 disorder, the manic episodes in bipolar 1 disorder are more common in males. Okay, males may have more manic episodes, and depressive episodes are more in females. And even rapid cycling is more in females. We'll talk about what is rapid cycling. Rapid cycling is when there are 4 or more such episodes in a single year. We'll talk about that in a while. So again, it is more commonly seen in females. Again, it is more common in the upper socio-economic groups. So again, certain studies have shown, so when we compare it to depression, there was no convincing data in depression related with the socio-economic status, but here it is seen in more in the upper socio-economic groups. Now, coming to the etiology, again, neurotransmitters, especially dopamine, is seen to be increased in mania. And again, genetic factors also play role. We've discussed that 70% again may be explained by genetics. Again, chromosome 18q and 22q, these two chromosomes have the strongest evidence. They have the strongest evidence for bipolar disorder, again important. And even chromosome 21q again may also be associated. Okay, now again, if you see in the genetics, bipolar and schizophrenia, they have an overlap. Okay, so many genes which are many areas which are known to cause bipolar disorder may also overlap with schizophrenia. Now let us talk about what are the symptoms of mania. So we already have discussed how to make a diagnosis of depression in depressive disorder. Similarly, same symptoms would be there if depression occurs in bipolar disorder. Now, the symptoms of mania you can remember with the mnemonic me dig fast. So someone is doing something very, very fast. Okay, so you can remember like this, me dig fast. So let us discuss these symptoms. So M, as it is a mood disorder, so M is the mood. How is the mood of the patient in mania? It is elated. There is elation. Person is excessively, without any reason, very, very happy, very cheerful. Sometimes patients may be irritable. What is irritability? Basically getting angry on small issues. Okay. Then second is E. E is energy. The energy of the patient is excessively increased. Patient feels full of energy. Patient may be doing multiple things. So there is an increase in energy of the patient. Then next is D. D is distractibility. So here person is very easily distracted. Okay, so patient is not able to focus on one task for a long time. Okay, so person is talking to you and suddenly there is a noise. Patients may shift his attention to something else, or he's doing something, he will leave it in between and start doing something else. Okay, so basically the productivity is decreased. Patient is very easily distractible. Okay, so there is distractibility. Then I is impulsivity. Patient is very, very impulsive. They may do things which again may have some harmful consequences. So out of impulse they may do. So many times there may be overspending may be seen. Overspending may be there. Okay, over socialization may be there. Patient is walking and may start socializing even with the strangers. He may not know these strangers, but just may talk as if he know them. Okay, or spend a lot of money without thinking. Family members may complain, sir, 10 lakh rupees he has wasted in buying all the useless things. Okay, or patient may there may be over religiosity. Over religious they may become. Okay, to the extent that it may hamper their health. They're just praying and doing religious activity for hours and hours. Okay, and also sometimes there is increase in there is hypersexuality. Okay, so there is increase in the sexual activities as well. So patient may be involved in a lot of impulsive activities. Then G is grandiosity. So grandiosity, or patient has an inflated self-esteem. Patient may enter the, your OPD, you're sitting in the OPD, and the patient may enter as if a king is entering. Patient may expect, that you should stand up and greet him as if a very important person has come. So there is an inflated self-esteem. Okay, while in depression, patient is very, very low. Patient's self-esteem may be very low, but here it is the opposite. Then F is flight of ideas. If you remember the basics of psychiatry we discussed, flight of ideas is basically the thoughts are moving very, very fast in the mind of the patient. So patient may speak, so many things, which is telling you the thoughts are moving very fast, and many times these thoughts, may be connected. Okay, like there may be rhyming words. So patient may, speak like this, I am the king, weather is spring, phone goes string, tring, pring, pring, bring, bring. Such, things which may rhyme or may be connected just by chance. Okay, so there is flight of ideas here. Now, next is A. There is increase in the activity levels of the person. Okay, patient may doing so many things, and the activity levels are significantly increased. Okay, although again these activities may be unproductive, but the activity levels are increased. Family members may say, sir, he's not sitting at one place. He's keep on moving. Even when you examine the patient may not be sitting and just may be involved in one or the other activity. Okay, then S is very interesting, is sleep. Now, what happens to the sleep of the patient in mania? There is a decreased need for sleep. So patient may say, or family members may say that, sir, he's sleeping very less, maybe just 1 or 2 hours in a day, and still the person is, full of energy. Patient may say, oh, sleep is a waste of time, I don't need sleep. So patient may just sleep very less and still be very active throughout the day. Okay, although, if we see in depression, when the patient was having sleep difficulty, the other day patient would say, sir, I am feeling very tired, but here the patient feels that there is very decreased need for sleep. Okay, so this is again very interesting in sleep. And T again is talkativeness. Okay, so T is basically patient is very, very talkative. So patient is just keep on speaking and speaking. At times, you want to, tell the patient to not speak, or to stop, but still the patient may be continuously talking. So talkativeness. Okay, so these are the symptoms, these are the symptoms in mania. Now, how to make a diagnosis? Again, according to DSM-5, both first two symptoms should be present. That is, there is elated mood or irritable mood, and the energy levels are high. So these two symptoms, along with this, 3 or more symptoms of the remaining, out of the remaining, if these are present. So again, as in depression, again here also, minimum of 5 symptoms if present. Now, duration in depression was 2 weeks. Here the duration is 1 week or 7 days, same as in ICD-11 also. So the duration is 1 week. Okay, if the patient is having these symptoms, we say patient is having a manic episode or mania. Now, if the mood is irritable, they say that the symptom should be, rather than 3, there should be 4 or more. Okay, just one thing, but again, you can just remember, if these, at least 5 symptoms present, then we call it as mania. Now, so again, just like depression, even in mania also, there may be psychotic symptoms present. Okay, so if a patient has mania with, delusions or hallucinations, we call it as mania with psychotic symptoms. Okay, now, so, patient may, say that, I'm the richest person on earth, I am the, I can do anything, I know the prime minister, the president. So if patient talks such false big claims, what is this? This is delusion of grandiosity. Okay, so delusions may be present. Similarly, if you talk to God, it is normal, but if the God starts talking back, patient says, I can talk to God and I can hear what God is speaking to me, then it becomes hallucination. So again, hallucination may be seen. Again, as you can see, it can be again mood congruent. So, the delusion, like delusion of grandiosity, I just explained you, or, voices, patient is hearing of God, or voices is telling the patient that, you're the richest person or you're the most important person. Again, they are consistent with the content of the mania. So they are known as mood congruent. And sometimes these may be inconsistent with the theme of mania. Like, patient is just having delusion of persecution. Okay, or he's hearing voice which are telling, that somebody wants to kill him. Such may be mood incongruent. So again, mood congruent and incongruent may be seen. Now, so, an example, a patient comes to you with, elated mood, as you can see in the image, very, very happy, excessive energy, lots of energy, and patient is speaking like this: my name is John, I want an iPhone, going to Rome, stone cold, John Ron. So what is this? Patient is speaking things which are connected by rhyming. This is flight of ideas. So here flight of ideas is seen. Okay, and again there is decreased need for sleep. Patient is sleeping very less and is spending a lot, involved in a lot of activities. And what is the diagnosis? And the duration they say is 10 days. So it is more than 7 days. So what is the diagnosis? It is mania. Okay, it is mania. Okay. Now let's talk about hypomania. So again, as you can see, just see the name, hypomania. Symptoms are similar but seems to be less severe than mania. So this is hypomania. So here the symptoms are similar to mania, but they're not severe enough to cause marked impairment of social or occupational functioning. Now please understand, someone who has mania, again his functioning will be severely impaired. Patient, may not be able to work in office, may not be able to, have social, functioning, well. But in hypomania, since the symptoms are less severe, so, again patient is having lots of energy, but the symptoms are not very severe. So sometimes this functional impairment may not be very significantly impaired. At times, patient in hypomania initially may, start doing many things. Patient may say that, so many things which have been cluttered since past 2-3 years, I have finished them all in this, in this state, because patient is having lots of energy. Okay, so in a hypomania you may see similar symptoms. Patient is having elated mood, energy is there, but again they may tell you that his functioning has increased. So that is suggesting you that symptoms are not very severe. That means patient is having hypomania and not mania. Okay, now again please remember, in hypomania you will not find flight of ideas. Flight of ideas is again characteristically seen in mania, and also psychotic symptoms also will not be seen. Okay, if psychotic symptoms are seen, that means the patient is now having mania. Okay, now also we have discussed duration of depression is 2 weeks, duration of hypomania is 1 week. What is the duration for? So duration of mania is 1 week and duration of hypomania is 4 days. Okay, so 4 days at least if the symptoms are there, we call it as hypomania. Okay, now also sometimes there is mixed episode. What is a mixed episode? Basically there are presence of both manic and depressive symptoms. So what happens, either in a day patient is at some time there are depressive symptoms, on another occasion there may be manic symptoms. So they may fluctuate in the day, or maybe some days it is manic symptoms, some days it may be depressive symptoms. Such episode is known as mixed episode. Okay, so patient sometimes can also have mixed episode, and the duration to make the diagnosis of mixed episode is again 7 days. Now then there is again an interesting concept known as rapid cycling. As the name suggests, the symptoms are cycling very fast. So what is rapid cycling? So it is seen in bipolar disorders. So patient with bipolar disorders having 4 or more episodes of mania, hypomania or depression in 1 calendar year, in 1 year. So in 1 year patient is having at least 4 discrete episodes. So patient's symptoms are moving up and down very, very fast. This is known as rapid cycling. So if you see this diagram, so in this is 1 year duration. Okay, this is 1 year duration, and if you can see, patient is having this is first episode is depression, then patient had mania, then hypomania, then again let us say patient has depressive. So there are 4 episodes, at least 4 episodes are there in 1 single year. This is rapid cycling bipolar disorder. Again, it is seen in rapid cycling bipolar disorder. Treatment is generally valproate is shown to have better effect in rapid cycling. So we'll talk about this in the management. Okay, now let's talk about the treatment. So we have discussed how to make a diagnosis of bipolar disorder. Let us try to understand how do we treat. So treatment depends on the phase of the illness. So whichever phase the patient is in, we'll treat that phase. Okay, so again first again in the acute phase, there is one is acute phase, in which we'll treat according to the phase, like there is manic or hypomanic, or there is depressive or mixed episode. Whatever is there, we'll treat that. And another would be maintenance or prophylaxis. Okay, so let us talk about the acute phase. So let us first talk about when the patient is in acute manic or hypomanic episode. Okay, now suppose a patient comes to you with elated mood, excessive energy, there is decreased need for sleep, activity levels are very high, and patient is speaking a lot, there is talkativeness. You made the diagnosis of mania. What is the first step? Let us, again, this is very important. Please try to understand the concept. Now, let us take this case scenario. So, as I've described, the patient has come to you in this mania or a hypomanic episode. Now, let us say, so it's a bipolar disorder. Let us say this patient in the past had a depressive episode and wherein antidepressants were present. So, let us talk about this scenario. And now the patient has come to you in a manic or a hypomanic phase. So what will be the first step? What is step 1? So what will you do first? So again, in such scenario, again, this is again a very important concept. What will be the first step? Will you start something? Any drug will you start for the patient? Of course, you will start some drugs, but what before that will you do something? So if there is such history, the first step will be that you will stop antidepressant. This is again very, very important concept. If a patient in mania or hypomania is on some antidepressant because of being treated for a previous depressive episode, first thing is you should stop antidepressant. Why so? Because what will antidepressant do? They will elevate the mood. But patient's mood is already so much elevated, so you have to first stop antidepressant. Of course, if no such antidepressants are present, then of course there is no need to stop any antidepressant. But if this is the case scenario, please remember, first step will be stop antidepressant. Then you think of starting any medication. Okay, let's talk about what all medications we can do. Okay, what all medications we can use. So there are 3 first line drugs. So antipsychotics, lithium, valproate, all these are first line drugs, okay, which can be used. Okay, again, antipsychotics like olanzapine, risperidone, quetiapine, aripiprazole, even drugs like cariprazine, again these are newer antipsychotics, they can be used, and many others can be used. Okay, so again we have 3 set of drugs which can be used which are considered as first line drugs. Now, so there is no one single drug of choice. Okay, so all these can be used as first line drugs, but of course there may be situation wherein you may prefer one over the other. Okay, now before this also please remember, lithium and valproate, these are also known as mood stabilizers. Okay, they are known as mood stabilizers. Okay, now let's try to understand some properties of some of these mood stabilizers. Okay, so let us discuss. So lithium, it's a prototypical mood stabilizer. It is said it's a prototypical mood stabilizer, but the onset of action may take some time. So patient is in acute state of mania, so drugs may take some time, may take at least 1 to 3 weeks may be taken for the onset of action. So if you start lithium, you may also have to add some other drugs, okay, like maybe antipsychotic or valproate or benzodiazepine for the initial, because lithium will take some time. Then valproate, now it has clinically we see that it surpassed lithium in acute mania because of rapid onset of action and better tolerability. So again, valproate is also an option. Carbamazepine, again, it is a mood stabilizer which is used, but it is not the first line drug. Okay, it is not the first line drug we use. Lamotrigine is also a mood stabilizer, but again it is used more for depressive episode in bipolar disorder. For mania or hypomania, it may not be that useful. Okay, now so let's come back to this. So we were discussing first line drug, we can use antipsychotics, we can use lithium, and we can use valproate. Okay, so now especially many times if you have to choose one, still you can go with these days you can go with antipsychotics. Okay, so if you still you have to choose one, otherwise all these 3 are first line drugs. Especially if suppose patient has psychotic symptom, then you may prefer antipsychotics, because again they will take care of the psychotic symptoms as well. Lithium and valproate, as we discussed, these are mood stabilizers. Now again, valproate, it can cause PCOD in females of reproductive age group, so you may not prefer. So suppose a young reproductive age female comes to you with mania or hypomania, you may not prefer valproate. You may prefer if other options are available. Of course, it's not that you cannot give, but if you can prefer, you may avoid valproate. Okay, and also don't give valproate if there is a hepatic disease. Okay, now along with these drugs, we also generally add benzodiazepines in the initial phase, okay, for the calming effect and for at times for sedation. We also add, for short duration, we also give benzodiazepines. Okay, now let's talk about certain conditions or certain situations wherein lithium is better, better, or we say correlates of lithium responsiveness, that in certain conditions lithium will have better response. So let us again, if these are given, it may, you may choose lithium. So in euphoric or elated mania, so if the mood is euphoric or is very cheerful, then lithium may be preferred. And generally we say in dysphoric mania is when the mood is irritable, then valproate may be, better. So again, you can choose, if there is dysphoric mania, you may consider valproate. Again, absence of rapid cycling, so if rapid cycling is not there, again lithium can be used. And we have, again we can, as we have discussed, valproate respond well to rapid cycling. So if there is rapid cycling, you may choose valproate. Absence of any comorbidities, again you can choose lithium. And valproate may respond well if there are other comorbidities. Okay, for example, let us say there are anxiety symptoms or some anxiety disorder is there along with mania, so then valproate may respond better. If 3 or fewer episodes are there, lithium generally responds well. If there are 4 or more episodes, then lithium response is not that much better. If there is MDI sequence is, suppose there is mania, then history of depression, and then there is an interval. If this is the sequence of symptoms, then it is seen that lithium may respond well. Again, family history of bipolar illness, and especially if there is a lithium response in some other family member, then again you can choose lithium. Okay, so these are some correlates of lithium responsiveness. Now let's talk about another important case scenario wherein patient has mania or hypomania and the patient is pregnant. So in pregnancy, so again the safest drug out of these three in pregnancy is the antipsychotic. So if pregnancy is there, you may prefer antipsychotic. Okay, suppose antipsychotic is not there in the option, or for some reason you may not start antipsychotic or they're not showing effect, then you may also prefer lithium. Right, when we talk about teratogenic effect, again lithium is teratogenic. It can cause cardiovascular defect like Epstein anomaly. It's a tricuspid valve abnormality. So again it can cause Epstein anomaly, but again the risk, first of all you should know the risk is low, 1:1000. And again it can be evaluated by high resolution ultrasound and fetal echocardiogram. You can evaluate, you can do these ultrasound echocardiogram in 6th week or 18th week of pregnancy, and it should be done. Now also one thing, during pregnancy, maternal lithium toxicity can occur at the end of pregnancy, because of there is a decrease in the lithium excretion. A lot of changes occur in the female during that delivery. So again lithium level should be monitored and adequate hydration should be given. Okay, so it's not that you can still give lithium in pregnancy, but if you have to choose one, the better answer will be antipsychotic. Now valproate, generally in pregnancy one should avoid valproate in pregnancy as much as possible. You should avoid. It causes again important teratogenic effect, neural tube defect. 1 to 4% risk is there in neural tube defect. Again if someone is still taking valproate in pregnancy, again if you have to give folate supplementation should be given, and especially 1 month before the conception. Okay, and it may also impact cognitive development. Again valproate may also affect cognitive development and can also cause low IQs. Okay, so as much if possible, try to avoid valproate in pregnancy. So if to choose one, antipsychotics are the safest. Now if since we are discussing pregnancy, let's talk about some other mood stabilizers. Carbamazepine, again it can also cause neural tube defect again, but the risk is lower than valproate. And again folate supplementation should be given 1 month before the conception. It can also cause other teratogenic effects like cleft palate, fingernail hypoplasia. And also when someone is on carbamazepine, vitamin K should be given to the mother and infant after delivery to prevent the hemorrhagic disease. And lamotrigine, again it's a mood stabilizer which is given for bipolar depression. Again it is seen to be safer than if you compare it with valproate and carbamazepine. It is seen to be relatively safer than these drugs. Okay, now if the symptoms are severe, in mania or hypomanic episode, if especially in mania, if the symptoms are severe, then we can also choose a combination. So lithium may be combined with antipsychotic, or valproate may be combined with antipsychotic, that can be used. Okay, if the symptoms are severe. Now So we have discussed, how to manage a, acute manic or a hypomanic state. Let us discuss, in acute depression, or what is, or in bipolar depression. So I'm sure now you can appreciate when I say bipolar depression, that means there has been in the past any mania or hypomanic episode. Okay, so now then there is depression. Okay, so is the treatment of bipolar depression different from unipolar depression? Yes. So in the unipolar or normal depression, we have discussed that we use antidepressants, okay, when we talk about psychopharmacology. Now here one important point is, this is again a very important concept you should remember. Don't use antidepressants alone. Okay, never start antidepressants alone. Why? So this is, this is a case of bipolar depression. There has been a previous manic or a hypomanic episode. Now in this patient, if you start antidepressants, patient has already have a history of mania or hypomania. So if you just give antidepressants alone, there is a risk of switch. Patient may land into a manic or a hypomanic episode. So risk, and so there is a switch. This is known as switch. So to prevent switch, you should not use antidepressants alone. And in drugs, if you see, risk is more with drugs like the TCAs, MAO inhibitors, and even to some extent to SNRIs. Okay, so to always don't give antidepressants alone in such cases. Now, so what are the drugs which we use? We can use mood stabilizers like lithium, lamotrigine, as we have discussed. Again, they can be used as monotherapy. Then quetiapine, again it's a antipsychotic second generation. Even lurasidone, again they can be used. They've seemed to be effective in bipolar depression. Again one combination, olanzapine and fluoxetine. Olanzapine again is a second generation antipsychotic, fluoxetine is an SSRI. This combination is seemed to be quite effective in patients with bipolar depression. And again, this antidepressant along with mood stabilizer. You can give antidepressant plus mood stabilizers like lithium, valproate, lamotrigine, that can be given. Okay, so this is how we manage a patient with bipolar depression. Okay, now after managing these episodes, then there is maintenance or prophylaxis. So to prevent the future episodes, or to prevent the severity of future episodes, we may give prophylaxis. So if especially if there are 2 or more episodes of these mood disorders, okay, mood episodes are there, or after a single episode of mania, there is a significantly high risk. The symptoms are very severe, and multiple medications were required. The risk is very high. Again, in such cases, you can give prophylaxis. And generally, we say in prophylaxis, lithium and valproate are used. And if you have to choose, many times it's seen valproate may be more effective. Okay, if you choose one, you may choose lithium. Otherwise, both can be used. And minimum duration for prophylaxis is at least 2 years. So patient is not having symptom, but we are giving it for prophylaxis. Okay. Now, so we talked about depression, we talked about bipolar disorder. Let's talk about some other mood disorders. Okay. First is dysthymia. Okay. First is dysthymia. Now, what is dysthymia? There are presence of mild depressive symptoms. Okay. So there may be mild depressive symptoms. For example, patient may have just sadness, or may have decreased energy or decreased interest. So there are few depressive symptoms, but they are not enough to make a diagnosis of a depressive episode. Please remember, to make a diagnosis, there should be at least 5 symptoms for continuous 2 weeks. No, here the number of symptoms are less, the severity is less. Okay, so they have some depressive symptoms, not fulfilling the diagnosis of a depressive episode. And minimum duration, they are present for at least 2 years. For at least 2 years, patient is having these mild symptoms. In children, we say take it as 1 year. If present for 1 year, in children we say it is dysthymia. Okay, so let us try to understand with the help of this diagram. Again, this is the line. Let us say if the patient touches, he is fulfilling a diagnosis of a depressive episode. Let us take this as 2 years duration. Okay, so here the patient says, sir, sometimes I am having low mood, sometimes I am having decreased interest, again, and these symptoms are continuously present since 2 years. So if you see in this diagram, the symptoms are throughout these 2 years, the patient is having some or the other symptoms. There may be some increase and decrease, but never he is touched this, or have a full-fledged depressive episode, and these are continuously present since 2 years. So this is how a patient with dysthymia may come to you. The patient may say, sir, I am having these symptoms. Although, again, these symptoms are not severe. They are not severe enough. So functional impairment functional impairment is not severe. Okay, functional impairment is not severe. So patient is having mild symptoms. So in the question you may get, patient may report, I'm having low mood, decreased interest, sometimes disturbance in sleep throughout the 2 years. Although I'm able to do all my work, I'm going to my office regularly, I'm taking part in social activity, but these symptoms are continuously present now since 2 years. So what is the diagnosis? Diagnosis is dysthymia. Okay, this is how we make the diagnosis of dysthymia. Now in DSM-5, there is a new term introduced, which is persistent depressive disorder. So they've removed dysthymic disorder and they've introduced this term persistent depressive disorder, which includes both chronic depression, so patient who is having depression for more than 2 years, and dysthymic disorder. So they have included both these under this persistent depressive disorder. Now there is another interesting term, again in literature there is another interesting term. Sometimes what happens after a dysthymic episode, let us say patient may ultimately develop a depressive episode. Okay, so there is a dysthymia and then followed by now the patient has a depressive episode. So this is known as double depression. This is known as double depression. So what is double depression? Patient has dysthymia, and after that patient now has a full-fledged depressive episode, or now patient has depression. So this is double depression. Okay, and if you remember in depressive disorder under the poor prognostic factors, we have learned that a patient with depression, having comorbid dysthymia is a poor prognostic factor. So this is what we have meant there. Okay, so patient has dysthymia, now he is having depression. This is in literature, this is also known as double depression. Okay. Now again, coming to the treatment, we can use antidepressants and also CBT can be used. Now, second mood disorder is cyclothymia. So again, the name says the symptoms are cycling. So it's a milder form of bipolar disorder. Again, patient has manic and depressive symptoms, but again, they are not severe enough to make the diagnosis of mania or hypomania or a depressive episode. Only symptoms are mild, symptoms are present. Again, the functional impairment, okay, is not very severe. Okay, so these are important points, which will tell you that symptoms are not very severe. So functional impairment is not that much affected. Again, the duration, again, these are persistent disorders again, so it is present for at least 2 years. Again, in children, if it is present for 1 year, we say it is cyclothymia. Again, let's try to understand with the help of this diagram. So let us say if this is 2 years duration, let us say this is 2 years duration. So in cyclothymia, patient report that there are days when I'm feeling low, then there are days when I'm feeling more than, happy more than normally, and my energy levels are high. Then again, there may be days when I'm feeling very low. So this is, how a patient with cyclothymia present to you. Now, if you see, patient has never, have a full-fledged depressive episode and also has never have a full-fledged manic or hypomanic episode. So this is how the symptoms may fluctuate. Okay, so again, this is cyclothymia. And again, in the treatment, we may use, an antipsychotic or mood stabilizer. Okay, may be used. Okay, so this is how we manage, and sometimes if antidepressant may be required, that may also be added. Okay, now next is premenstrual dysphoric disorder or PMDD. So let's try to understand what is PMDD. Now it's a new diagnosis in DSM-5. Even ICD-11 has also reduced this diagnosis, but there they have not, they've put it under diseases of genitourinary system and not under the mental and behavioral and developmental disorders. Okay, now what are the symptoms? So it's a premenstrual. So the onset of symptoms occur 1 week before the menses. They start to improve after the menses have started, after the onset of menses, and the symptoms are minimal or absent in the week post menses. Okay, so this is how characteristically the symptoms generally have the course in. So they will occur in a month, they will occur for few days, and this is how they will present. Okay, now, so what are the symptoms? You can remember the symptoms with the mnemonic. So in PMDD, PMB, so you can remember it with the mnemonic PMB. There are physical symptoms, So patient may complain of breast tenderness, joint pain. Then, please see in the name itself, it is dysphoria. So mood symptoms are there, like there may be depressed mood, irritability may be there. Then behavior symptoms may be there, insomnia, changes in eating pattern, or edema may be there. Now, so these symptoms, they should be present in at least 2 symptomatic cycles. So if they're present in at least 2 cycles, okay, then we say patient is having PMDD. Again, treatment is again symptomatic management, like you can give for pain, you can give NSAIDs. So pain symptomatic management may be there, and also SSRIs like fluoxetine or benzodiazepines may also be given. So this is PMDD. Okay, you can remember with the mnemonic PMB. Now, again, PMDD should be differentiated from premenstrual, syndrome. Premenstrual syndrome, as the name suggests, here the symptoms, 5 days before the menses. The symptoms are present 5 days before the menses, and generally the symptoms here are physical symptoms like breast tenderness, headache, and mood symptoms are there. Irritability, sadness, or anxiety may be there. Okay, so the pattern is different from PMDD. Okay, so this is how you can differentiate. Now, let's talk about some psychiatric aspects of, pregnancy. Now, first is postpartum blues, or also known as baby blues. Okay, postpartum means basically after delivery. Okay, so postpartum blues, blue is, a term used when the person is sad. There are songs, feeling blue. So, this is denoting sadness. So, what is postpartum blues? Again, it is seen in 30 to 75% of women after childbirth, and the onset generally starts 3 to 5 days after childbirth. Okay, now symptoms generally are there transient, mood symptoms, depressive symptoms like sadness, mood lability, tearfulness may be there, irritability may be there, sleep disturbances may be there. So these are transient symptoms, temporary symptoms. They may last for a few days to weeks, and subsequently they will resolve spontaneously. Okay, so again, it's common, 30 to 75% of the women may, experience such changes. Again, symptoms, more severe symptoms, like anhedonia, suicidal thoughts of harming the baby, they are generally not seen in postpartum blues. Okay, and generally guilt may be, absent, or it will be very mild. Okay, and there is, history of mood disorder or any family history of mood disorder is generally not seen. Okay, such associations are not seen with postpartum blues. Okay. So again, there is no professional treatment required. Support to the mother is essential, who's given just, the birth, and again, reassurance and supportive management is enough. If the symptoms are present for more than 2 weeks, then you may have to evaluate it for postpartum depression. Okay. Now, so let's talk about what is postpartum depression. Okay. Again, 10 to 15% of the women after childbirth may experience postpartum depression. Onset, generally we say is within 3 months of delivery. Now again, in the guidelines like DSM-5 says it is, within 4 weeks, but up to, sometimes 3 months, we can still, take it as postpartum depression. There is an increased risk of depression in future. If a person has postpartum depression, there is an increased risk of developing, another episode of postpartum depression in the, future pregnancies. Now, again, here the symptoms, there is depressed mood, insomnia, change in weight, these are seen. And now, again, tearfulness, mood lability, again, as in postpartum blues is present. Now, more severe form of symptoms like anhedonia, guilt, they are often present. Suicidal thoughts of harming the baby, again, they are also present sometimes. And there may be a history of mood disorder, previous history may be there, and family history also may be seen. It's not always, but again, there may be strong association with this. Okay, so again, this is typically telling me that patient is not having blues, but now patient is having a depressive episode. Then again, in the treatment, here you would require treatment. Again, pharmacotherapy and psychotherapy may be required. Now, there is an interesting novel drug. We have discussed one novel drug there, when talking about depression, as ketamine. Now, there is another drug, brexanolone, okay, which is again a newer drug in 2019. FDA approved it for one particular condition, that is postpartum depression. This drug is specifically used for postpartum depression. Now, there is an IV, its IV infusion is given, and continuously it is given for 60 hours. Now, it is an identical endogenous allopregnanolone. So, allopregnanolone it is. So, you can see from the name brexanolone, pregnanolone. So, you can remember from the name, it's a identical, it's identical to this endogenous allopregnanolone, which decreases after childbirth. And it's a positive allosteric modulator of GABA A receptor. Okay, it works on GABA A receptors. Again, it has rapid effect, just like esketamine, normally, typically we have discussed the antidepressants take time, but drugs like esketamine and this brexanolone, they generally have rapid onset of action. Now again, adverse effects may be seen like sleepiness, dry mouth, loss of consciousness, okay, and flushing. These are some of the side effects with this drug. Okay, so this is approved only for postpartum depression. Then there is postpartum psychosis. Again, the incidence is 1 to 2 per 1000 childbirth, and again onset is again within 2 to 3 weeks of delivery. Now here, after the initial symptoms of like insomnia, tearfulness, mood lability, fatigue, these are initial symptoms. These are followed by psychotic symptoms like delusions and hallucinations. Now the patient have delusions and hallucination, and generally the content may be related with the baby. For example, patient may develop such delusion that this baby is not mine, or I have not delivered any baby, I didn't had any pregnancy. So it may be such delusional beliefs. Or patient may report of hallucinations like hearing voices to kill the baby. Okay, so again they may be related with the baby. Okay, but again in these situations, though we generally don't recommend to separate the mother from baby, but you should keep them in supervision. Okay, now again something 50% things are seen in postpartum psychosis. So 50 to 60% these episodes occur in the first child, birth of the first child. In 50% of the cases we see there is a family history of a mood disorder. 50% of the deliveries are associated with non-psychiatric perinatal complications. So there may be some other complication, non-psychiatric complications, like there may be hemorrhage, or there may be some other complication may be associated. Then risk of another episode, there is a 50% risk of another episode of postpartum psychosis. Okay, now it's a psychiatric emergency. Many times patient may try to harm the baby, so it's a psychiatric emergency. Again, antipsychotic along with lithium may be given, and often sometimes in combination with an antidepressant may be given to the patient. So after the delivery, patient is having tearfulness and sadness, decreased sleep, not very severe symptoms. Okay, and there is no other complication again. So what you should think of? You should think of postpartum blues. Okay, if the patient has more severe symptoms, anhedonia, suicidal thoughts are there, then you should look for, there is excessive guilt, you should then look for postpartum depression. Okay, now along with these symptoms, if the patient has developed delusions, hallucination, then this is postpartum psychosis. Okay, so this is how we can differentiate. Okay, let's talk about now suicide. Now rate of suicide in India, now if we see decades of data, recently the risk, the rate has increased. It is 12 per 1 lakh population according to the latest NCRB, that is National Crime Research Bureau data, Record Bureau data, NCRB. Okay, the 2021 data, it is 12 suicide per 1 lakh population. Okay, the National Crime Record Bureau. Okay, most common method, if you see, it is in India, most common method is hanging. Okay, followed by poisoning. Now again, there are many psychiatric disorders which have associated with higher risk of suicide. Depressive disorder, discussed, depression is the most common psychiatric disorder associated with suicide. Then other disorders like schizophrenia, bipolar disorder, alcohol use disorder, even personality disorders like antisocial personality disorder, borderline personality disorder, they may have higher risk of suicide than general population. Now also it is seen that low CSF levels of serotonin metabolite, which is 5-hydroxy-indole acetic acid, 5-HIAA. Okay, so this is associated with, so low levels, CSF levels of this 5-hydroxy-indole acetic acid is associated with higher risk of suicide. Okay, associated with higher suicide risk. Now then there are certain risk factors in suicide, most important risk factors. So if you have a patient, there may be many factors, but one most important factor if present in the patient. So patient is having suicidal thoughts. and there is a previous suicide attempt, so there is a history of previous suicide attempt is there, then it poses the greatest risk. Okay, so be very very cautious in such patients. So there is a history, patient has tried attempted suicide before, it's a most important risk factor. Another important risk factor is presence of hopelessness. If you remember, we discussed cognitive triad of depression, so worthlessness, helplessness and hopelessness. So hopelessness, there is no future, no hope in future, everything is dark. So patient if has such thoughts, again be very cautious, again it is an important risk factor. Then there are other risk factors like again males, females may be ahead in males in many other fields, but here the risk is more with males. Why so? Because risk is more, we're talking about completed suicide is more with males because males may use more lethal methods. Okay, then age more than 45 years again is a risk factor. Nowadays even in the youth the risk is increasing. Okay, then any signals of suicide intent, like patient has written suicide note, or patient has is meeting his relatives long after long time, maybe so this may indicate maybe they have planned, these are signals of suicidal intent. Okay, then person who is divorced, separated, single, again they pose more risk. Someone who is employed again is a increased risk factor. Then other factors like patient is having some chronic illness, there is some pain or some some problem which is continuously present for a long time, then again that may increase. Delusion, hallucination, patient in delusion or hallucination, patient is hearing a voice which is telling him to jump and patient may just jump. So again these psychotic symptoms may increase the risk. Substance use, again many times patient under the influence of some substance may commit suicide. Then poor social support, there is history of any sexual abuse or a family history of suicide. Again these are some of the risk factors for suicide. Now there are certain important terms like paradoxical suicide. Now what is paradox? Paradox means something which you're not expecting. So what is paradoxical suicide? So paradoxical suicide is in the initial stages of treatment or recovery, patient has attempted suicide. So patient, let us say, is having depression and suicidal thought, but patient has not attempted. You start treatment and after some time the patient has attempted. So this is the paradox. When he was not started on treatment, there the patient not attempted, but now when the treatment has started or in the recovery phase, patient has attempted. Why this is happening is because there is gain of energy. So patient says initially when patient was having depression and suicidal thought, he didn't have that much energy to even attempt suicide, but after the start of treatment there was gain of energy, but suicidal thoughts still were there. They may take time to resolve, so that time the patient attempted. So this is paradoxical suicide. Then there is something known as copycat suicide. What is copycat? To copy someone. So copycat suicide is mimicry of another's suicide method, which the patient or which the person attempting suicide know by local knowledge. Let us say someone in the area he heard that someone attempted suicide, okay, let us say by hanging. So person also tries to mimic that, or let us say through through media, patient some celebrity or someone has attempted suicide, so person may attempt it in a similar way. So this is copycat suicide, again more common in adolescents. Okay, then parasuicide. What is parasuicide? It is self-injurious behavior. Again, so patient may indulge in certain self-injurious behavior, but there is no intention to kill themselves. So these are not very severe injurious behavior. So you may find that there are certain intention wound marks on the wrist, so the intent is not to harm. Okay, so this is parasuicide. Okay, now there are certain features, of depressive disorder. So we know that patient having depression may in future may develop a manic or a hypomanic episode, and that will change the diagnosis to bipolar disorder. So are there any features which occur in depressive episode which may predict that in the future patient may develop into a bipolar disorder? So some of the features are like if it occurs at early age of onset. Usually we have discussed depression is more common in mean age was 40 years. So again in the 30s may be more common, but if it occurs at an early age. Psychotic depression occurs, and especially if it occurs before 25 years of age. Again, postpartum depression, especially if there are psychotic symptoms, again it is more a predictor of bipolar disorder. recurrent depression, again if especially more than 5 episodes, atypical depression, or if there is seasonal depression again. So if you can see, many of these depressives specifiers are hinting, if they're present, it may predict towards bipolarity. Again, if the episode is of short duration, less than 3 months, the patient started on and off, in just 3 months the symptom become well, so again it is predictor of bipolarity. If there is a family history of bipolar disorder again, and person has a depressive episode, again there is chances that the patient may have bipolar disorder. And if there is a significantly increased family history of mood disorders, okay, so if there is very high density of such episode disorders in the family, again it's a risk of bipolar disorder. Okay, so these were some important mood disorders.
So now let's talk about lithium. So we'll talk about some more details about lithium. So as we have discussed, lithium is it's a mood stabilizer. It's a mood stabilizer. Now, John F. J. Cade, an Australian psychiatrist, he established the effectiveness of lithium for mania as well as prophylaxis of bipolar disorder. So again, an important person related with lithium. Now, lithium structurally is what? Lithium is a monovalent ion. It's a cation. And it gets completely absorbed after oral administration. It is completely absorbed. And it does not bind to the plasma protein, and it is not metabolized. It is not metabolized in the body, and it is excreted through the kidneys. The plasma T-half of lithium is 1.3 days, and it increases to 2.4 days after continuous administration of lithium for more than 1 year. So the T-half increases. Generally, when we start lithium, the equilibrium is reached after 5 to 7 days of regular intake. Now, let's talk about some indications of lithium. First is manic episode. So, the first indication is manic episode. Now, lithium is effective to control acute mania. So, in acute mania, lithium is shown to be quite effective, but due to slow onset of action, it generally takes 1 to 3 weeks for the onset of action. It is at times given along with a benzodiazepine or an antipsychotic or valproate, so that the effect, these drugs may take care of some of the effect, because lithium may take time for the onset of action. And it is also used as a prophylaxis to prevent further episodes. Then also it can be used in bipolar depression. It is effective in treatment of bipolar depression as well as its prophylaxis, although it is seen that it is more effective in prophylaxis of manic episode than depression. Now, also it is used as a maintenance therapy, and in the maintenance therapy it is seen lithium decreases the frequency, severity as well as duration of manic and depressive episodes in person with bipolar disorder. So in fact, when we talk about maintenance, we use lithium and valproate, and many times we may prefer lithium over valproate in the maintenance. Lithium also has anti-suicidal effect, and it reduces the incidence of suicide in patients with bipolar disorder. It is also used as an adjunct treatment. So in major depressive disorder, it is not used as a monotherapy, but in major depressive disorder, it can be used as an adjunct treatment along with antidepressants, as well as even schizoaffective disorder. It can be used as an adjunct treatment along with antipsychotics. So it can also be used in these conditions as add-on treatment or adjunct treatment. Lithium has also been used in various other conditions such as aggression, OCD. Some of the neurological conditions like headache, like cluster, migrainous headache, movement disorder, even epilepsy, it has been used. Then neutropenia. Lithium is shown to have granulocyte stimulating effect, so it has also been used in neutropenia. Then certain dermatological conditions like genital herpes, seborrheic dermatitis, even ulcerative colitis, and even historically it has also been used for treatment of gout. So these are some other indications. Now, let's talk about side effects. So lithium has various side effects. First are the neurological. Let's talk about neurological side effects. So lithium can have, person who is taking lithium may have postural tremors. So when postural tremors, like you outstretch hands, you may see there may be tremors. So it may usually are of 8 to 12 hertz frequency, and person who has had lithium induced tremors, the treatment is beta antagonist like propranolol. Then other neurological adverse effects may be lack of spontaneity, memory deficits may be there, seizures may be there, Rarely, peripheral neuropathy, benign intracranial hypertension may also be seen with lithium. Now, endocrinal side effects like hypothyroidism. Again, hypothyroidism is an important endocrinal side effect associated with lithium, and it is seen to be more in females. The risk is more in female, and also so someone taking lithium and is having rapid cycling bipolar disorder. Again, in those patients also it is seen that the risk of hypothyroidism may be more. Then other endocrinal abnormalities like hyperthyroidism, hyperparathyroidism may also be seen with lithium. Now let's talk about renal side effects associated with lithium. Now most common is polyuria, which can subsequently lead to polydipsia, even can also lead to diabetes insipidus. So basically it occurs because lithium inhibits the effects of antidiuretic hormone. So it inhibits the effect, so there is polyuria. Now when we talk about the treatment of this symptom, fluid replacement is one of the steps which we do, and subsequently drugs may be used like thiazide or potassium sparing diuretics. Now again, it is important to know when we start drugs like thiazide diuretics, what they do is they decrease the lithium clearance. So thiazide diuretics we are using because of polyuria, but what is it is seen is that it has drug interaction with lithium and it decreases lithium clearance. So what happens is that if one gives thiazide, there may be increase of lithium levels. So there may be chances of lithium toxicity. So whenever we start patient with such drugs, the lithium should be decreased, and in this case lithium dose is reduced to half. Now also, rarely it can cause certain other renal effects, like it can cause non-specific interstitial fibrosis, nephrotic syndrome, and also can cause distal renal tubular acidosis. Now in dermatological condition, it can cause acne, psoriasis, it can cause hair loss or alopecia, and even can cause rash. Some other effects associated with lithium include benign T-wave changes, nausea, vomiting, there may be diarrhea, and also it can cause weight gain. Now, teratogenic effects associated with lithium. So a female pregnant female, taking lithium, it can lead to some teratogenic effect. So lithium, if taken in pregnancy, can lead to Epstein anomaly of the tricuspid valve. And the risk in lithium exposed fetus is 1 in 1000. But the risk is, it is 20 times more than in the general population. If we compare it with the general population, the risk is 20 times more. But if we compare it with other drugs like valproate and carbamazepine, the risk is lower than the teratogenic effects produced by valproate or carbamazepine. Now again, let's briefly also talk about some drug interactions of lithium with various drugs. So drugs like diuretics, thiazides, potassium sparing diuretics, ACE inhibitors, and non-steroidal anti-inflammatory drugs, except aspirin and Solindac, all these drugs, they increase the lithium concentration. So when we are giving lithium along with these drugs, we have to decrease the dose of lithium because lithium concentration increase and it can also reach the level of toxicity. While drugs like loop diuretics, osmotic, xanthine, carbonic anhydrase inhibitors like acetazolamide, these drugs, they increase the lithium clearance via the kidneys, and subsequently they decrease the lithium concentration in the body. So lithium dose have to be increased when we are giving these drugs along with lithium. Now, when we have to check the levels of lithium in the blood, when one should take the blood sample. So blood sample should be taken 12 hours, plus minus 30 minutes after the last dose. So suppose the patient has taken in the night, person has taken the lithium, then in the morning, 12 hours later, before giving the next dose, we have to take the samples 12 hours. So there should be a gap of 12 hours. Or if the patient has taken it in the morning, so 12 hours later in the night, before giving the night dose, one has to take the blood to check the lithium levels. Now the therapeutic range, it is a narrow therapeutic index. The therapeutic range is 0.5 to 1.5 milliequivalent per liter. In acute mania, the range of the level should be between 1 to 1.5 milliequivalent per liter. So we adjust the dose so that the range is between 1 to 1.5 milliequivalent per liter in blood. And for maintenance, it should be around 0.6 to 1.2 milliequivalent per liter. Toxicity generally starts when it is more than 1.5 milliequivalent per liter. Now, when lithium toxicity occurs, some of the risk factors it may include if one is taking excessive, exceeding the recommended dose, then of course lithium levels can increase. If there is renal impairment, so again if there is renal impairment, the lithium is not getting excreted properly, so again it can increase the levels in the blood, reaching to toxicity. And even in certain drug interactions, as we have discussed, lithium clearance may decrease, and again the levels of lithium may increase in the body. Now also let's try to understand. So the body treats lithium just like sodium. So in certain conditions like low sodium diet or dehydration, what happens that there is low sodium, so the body tries to absorb sodium, and since it treats lithium like sodium, it also would absorb lithium, and subsequently it will lead to toxicity. So patient taking lithium and is dehydrated, let us say is fasting, so again the lithium levels may increase. So or maybe let us say person is having vomiting or diarrhea, again in these conditions the lithium levels may increase. So let us now learn what would happen or what kind of symptoms would occur if someone would develop lithium toxicity. If it is of the range of mild to moderate, so somewhere between 1.5 to 2 milliequivalent per liter, so then there may be GI symptoms like vomiting, abdominal pain, or CNS symptoms like ataxia, nystagmus, muscle weakness may be there. If it increases to moderate to severe levels between 2 to 2.5 milliequivalent per liter, then there may be again GI side effects of anorexia, more nausea, vomiting, and CNS effects like hyperactive deep tendon reflex. There may be convulsions, stupor, or even maybe coma. And in severe lithium toxicity, when the levels is more than 2.5 milliequivalent per liter, there may be generalized convulsions, oliguria, renal failure, even death may occur. So death can occur because of lithium toxicity. So one have to be very careful when the person is taking lithium. Now, treatment of lithium toxicity is, first is yes, we have to stop lithium and you have to correct hydration. Then for removal of unabsorbed lithium from the GI tract, we can use polyethylene glycol or we can use sodium polystyrene sulfonate. Activated charcoal generally is shown to have no effect. So activated charcoal may not have any role in the treatment. Now in severe cases, hemodialysis may also have to be done. So clear out the high lithium levels in the blood. And sometimes, after performing one hemodialysis, again because of redistribution, again the lithium levels may increase. So multiple hemodialysis may have to be done in the treatment of lithium toxicity.